presentation, okay, which I am attending, but first time I am seeing such a big crowd. So I used to moderate student sessions. That used to be very easy, okay. First I am moderating faculty session. Let's see how they maintain the time. So we have 8 minutes presentation and 2 minutes questions, okay. So first presentation by Dr. Namrata. She is going to present on a structural faculty leadership development curriculum with evaluation tools for health profession education.
Everyone. And thank you for the opportunity to present my project. Today I want to share a story about what happens when faculty are given structure and tools to become leaders, what their institutions want them to be. It is the story of a program, leadership and organizational change. And it is a mixed method pilot study. So let's begin by exploring the core of our challenges, what I refer to as the leadership paradox. So we expect our faculty members to be medical educators, researchers, and inspiring leaders. We provide excellent training opportunities for the first two, but what about leadership? We want our faculty members to lead curriculum change, manage teams, mentor learners and junior colleagues, and drive organizational changes. But the reality is most of the faculty members have no formal leadership training. Programs exist, but they are short and fragmented. And the issue extends beyond formal training. The evaluation methods are weak. The change in behavior and identity formation are mostly overlooked. And the professional identity as a leader remains largely unaddressed. So why this program? We wanted to go deeper. We wanted to ask better questions beyond satisfaction surveys. So we started with 3 questions, and our goal was not just knowledge transfer, but holistic professional identity formation. And the questions were, can training reshape a leader's identity? Can it change the way leaders think, lead, and engage? And can it influence how they see themselves? So we started with 3 objectives. First, to design a theory-informed structured curriculum, and secondly, to implement it across multiple faculty cohorts to ensure its consistency, and evaluate the depth of this program rigorously by asking deeper questions. It wasn't a weekend workshop, but 14 weeks intense academic journey. It was leadership and organizational change course within a master's in health professions education program at AUA. 15 faculty members across 2 cohorts participated in the study, and the mode of delivery was for the hybrid. Multiple data sources were used to evaluate the quality of this program. So what was special about this blueprint for growth? We didn't start from scratch, but we integrated 2 established models. Conger's model acted as an engine for the academic journey and guided us on what and how to teach, and the Kirkpatrick model helped us to justify the evaluation strategies of this program. Conger's model is a learning loop. It starts with conceptual understanding and then leads to skill building, and feedback is collected, and all that leads to personal growth. For input and for building the concepts, we used lectures, discussions, and literature reading. for skill building, we used simulations and role plays, and feedback was multi-source feedback, my feedback as a course director, and peers critique. The elements of personal growth were weekly reflections, personal development plans, and teaching philosophy statements. And we intentionally curated the curriculum, including all the humanistic principles of leadership. And this is the dashboard where we evaluated all the 4 levels, right from reaction, learning, behavior, and the personality transformation by asking deeper questions. And our data collection tools were semi-structured questionnaires, multi-source feedback, personal development plans, and weekly reflection journals. And what happened? What were the dimensions of change after 14 weeks of intense academic journey? When we analyzed the rich data, we got 4 themes, each depicting the different stages of growth. The first one was self-awareness. The quote from a participant says it all. Self-awareness was the foundation of being an intentional leader, and self-awareness led to collaborative confidence. And active strategy was the third theme. Our participants started applying theory into practice. And finally, it was a moment of transformation. You can see the teaching philosophy which was updated. It wasn't a skill, but a sustained shift in mindset, identity, and behavior. So what are the final takeaways? Firstly, about leadership. It is not about position, title, or trait. Leadership is about knowing the purpose, knowing yourself, and committing to personal growth. And leadership development works best when it is reflective, contextual, and feedback-driven. Literature says so. Our participant lived it and proved it. And this is the core theme of our program. Leadership is a behavior. It is systematically teachable, measurable, and transformable. So that was about leadership. And about our program. This program is effective because it is structured, theory-informed, and evidence-based. And the tools are adaptable and scalable across settings. And this dual integrated framework model offers a replicable and scalable approach for institutions. So I leave you with a final thought. When faculty reflect deeply, lead empathetically, and act strategically, they don't just change organizations, they change cultures. These are my references, and thank you so much. Thank you to all the participants who believed in me, trusted in the process. Thank you. I'm open to questions and discussions. Thank you.
Thank you for being on dot. So, is any questions? Any questions from audience? From students? Okay, thank you.
Thank you so much.
Oh, there is one question.
I had a simple question. What was your sample size?
My sample size was 15, and this is a limitation because the sample size was small, and I mentioned early in the beginning it was a pilot run, and we are going to expand it further.
So you sort of did a mixed methods study, am I correct? You know, where you
Yes,
collected the quantitative data and then the qualitative data. Did you link it together?
Yes, it was quantitative as well as qualitative. What I have projected is just the thematic analysis of the qualitative data. Yes.
So do you have any thoughts about the best point in one's career for doing leadership training? When does it work best?
Sorry, can you please repeat the question?
When does leadership training work best for people? Earlier in their careers, later in their careers? At what point does it make a best difference?
Anytime. We are leaders at home also. Yes.
Hi, Dr. Chopra. Thank you so much for your research. Based on your findings, can it answer the old adage question, are leaders born
No.
or are leaders made?
That's what I said. Leadership is not a trait.
Okay.
It is teachable, measurable, and transformable.
Okay.
So we used to say we are born leaders, and that's a myth. I busted it.
Thank you.
Thank you.
Thank you. So next speaker, Dr. Radhika, she is going to present on maternal adherence to safe infant sleep recommendations and disparities in the USA, findings from PRAMS 2016 to 2022.
Good afternoon. Thank you for the opportunity to present my work on maternal adherence to safe infant sleep recommendations and disparities in the United States, findings from the PRAMS Phase 8 data. My co-authors are from my department, Dr. Carolyn Edmondson, Dr. Jovita Herrera, Kasim, and Dr. Acuna. So sudden unexpected infant deaths refer to sudden and unexpected deaths in the first year of life, and they are important causes of post-neonatal mortality in the United States. Despite the American Academy of Pediatrics recommendations on safe infant sleep practices, these deaths have kind of stagnated over the last 2 decades, contributing to almost 3,000 infant deaths annually in the United States. The Pregnancy Risk Assessment Monitoring System, that's the PRAMS surveillance data, permits us to examine the maternal behaviors related to safe infant sleep practices. The American Academy of Pediatrics recommendations include a safe infant position, that is back position, a safe surface, that is a firm surface such as a crib or a bassinet, safe location, room sharing, but no bed sharing with the mother, and safe bedding, that is in a sleep sack without any cloth, without any blanket or any soft toys. So the objective of this study was using PRAMS Phase 8 data to estimate the prevalence of maternal adherence to safe infant sleep practices and to identify the socio-demographic and behavioral correlates of non-adherence to these practices. So this was a secondary analysis of the PRAMS data, and the inclusion criteria was mothers with singleton births and mothers who provided information on all 4 safe sleep practices. We used the American Academy of Pediatrics operational definitions. As you can see, the PRAMS Phase 8 we used the weighted data, and the final sample size included 2,500 women, and the weighted data corresponded to about 6.3 million. The exclusion was largely because of missing data on sleep surface and was largely due to missing data on sleep location and safe bedding. So these were the correlates which we used. The demographic correlates included age, the race and the ethnicity, education. Instead of income, we used surrogate correlates, the Medicaid and mother, whether she whether she was a beneficiary of any nutritional assistance program. The behavioral correlates that we included her marital status, whether the pregnancy was intended or unintended, the prenatal care utilization, the adequacy of the same, whether the mother continued to breastfeed at the time of the survey, smoking after childbirth, depression, this is a self-reported depression, whether a mother reported depression after childbirth, and we also included infant maturity and birth weight of the baby. So our reference group was safe practices, and the risk group was mothers who reported unsafe practices. So as I mentioned earlier, PRAM's data, we use a weighting plan. So we calculated the weighted period prevalences for the safe practices, and to identify the associations with unsafe practices, we used the regression models, and the associations were expressed as adjusted odds ratio with 95% confidence intervals. Because we had a large percentage of excluded data, we did a sensitivity analysis between the included and the excluded data for 2 of the practices which had the maximum responses. So this was the prevalence. As you can see, nearly 80% of the mothers who answered the survey adopted safe supine position and safe room sharing with no bed sharing. However, the complaints to safe sleep surface and safe bedding was poor, and it was seen just in about 1/3 of the mothers. Concurrent safe and unsafe practices were more common with sleep surface, but when it came to the safe bedding, unsafe practices were more common. In fact, what we found was none of the mothers adhered to all the 4 safe infant sleep practices, and however, 99% of the respondents followed between 1 and 3 safe practices. Our results showed persistent racial and ethnic disparities. Non-Hispanic Black mothers had higher odds of unsafe sleep behaviors, including unsafe position, unsafe location, surface, and unsafe bedding compared to non-Hispanic white mothers. Again, indicators of lower socioeconomic status such as low education, Medicaid coverage, and WIC enrollment remained associated with unsafe sleep positioning and unsafe bedding. Inadequate prenatal care utilization showed small but significant associations with some of the outcomes. Smoking and depression were strongly linked to unsafe surfaces and bedding. However, adherence increased with maternal age. Education of the mother, especially if they were graduates and above, good adherence was seen, and mothers who received healthcare counseling also reported safe practices. So this is the forest plot showing the adjusted odds ratio. I think I don't have a pointer. But as you can see, one of the most important association was the race compared to the non-Hispanic white mothers. Unsafe practices where higher odds ratio was seen, higher adjusted odds ratio was seen for unsafe practices, almost all the 4 unsafe practices among other races. And similarly, what we saw was Medicaid. If the mothers were Medicaid or WIC beneficiaries, suggesting that they were from the low socioeconomic strata, again the adjusted odds ratio for unsafe practices was high. What was protective, as you can see, is mother being a graduate, and whenever there was a lack of health care worker counseling, again we saw a high adjusted odds ratio for unsafe behaviors. So our results substantiated that persistent gaps remain in the implementation of safe infant sleep recommendations. Racial and ethnic disparities are among the strongest predictors of unsafe practices and mirror the suit's mortality patterns, which is the highest among the non-Hispanic black mothers. The disparities also reflected a combination of parental choices, cultural norms, systemic inequities, and limited access to safe sleep resources. Healthcare workers played a central role in shaping parental decisions. The limitations, perhaps, is a cross-sectional design, so we cannot have a causal inference. The data entirely report on maternal self-report subject to recall and social desirability bias. This was also reflected in the high percentage of missing data. Excluded respondents, when we did the sensitivity analysis, the excluded respondents showed characteristics associated with socio-economic stress with potential selection bias, and this may attenuate or inflate some of those associations which I reported, particularly the racial and ethnic disparities. Our findings underscore the need for comprehensive safe sleep strategies that extend beyond back sleeping to address sleep surfaces, bedding, and bed sharing practices. There is a need for culturally responsive, family-centered, and healthcare provider-driven interventions that promote safe infant practices integrated into the maternal and child health programs to reduce the persistent disparities. A disclaimer, this study is already published in BMJ Pediatrics Open. I would like to thank my colleagues and also acknowledge the support from AUA for the research grant. Thank you.
Thank you very much. Any questions?
I know there are a lot of pediatricians in the audience. I'm aware of that.
Hello, good afternoon. Dr. Beljavis, pediatrician and medical director at the Celeste Bird Medical Center. Excellent presentation and very timely because now at the Celeste Bird Medical Center, in collaboration with Consumer Affairs, we're actually doing an educational drive as it relates to safe sleep. And we have been striving to get across the ABCs of safe sleep: alone, the back to sleep, and using the crib. The challenge that we've had, though, is the cultural element. Most persons, and I believe many of us here, believe that a baby sleeps longer, right, when they're on their tummies, and that has been a significant challenge. The second challenge that we've had is that most parents say that they were not educated during the antenatal period about safe sleep techniques. Would you consider doing a possible collaboration or even study looking at knowledge and gaps? So what are the practices before educational intervention, and then the sustainable changes that are implemented? So we educate, we assess first, educate, and then we reassess to see if there's a sustainable change. Because the influence of grandmother, grandfather, auntie, put the baby on the belly and the baby will sleep longer.
Definitely, it would be my pleasure.
So we can look into it. Thank you.
Thank you.
Thank you for a great presentation, great work. We have several clinical trials that do show that this program actually works. And so another way of seeing what PRAMS is reporting, which is really what mothers actually reply, it provides a sense of how much the message is actually getting to different population groups. And so from that perspective, and it seemed that part of the challenge I think you described is that some of the key questions are not being addressed, and I think you ended up with something like 45% exclusions because of missing some of the information. But even with that, what would you do next in terms of what could be done to try to move in the direction of increasing the, going back, and hopefully that reducing even more or having more benefits.
Yes, one of the things that came out in the study was, I didn't present some of the data which were published. So this room sharing without bed sharing, and again I subdivided the group into mothers who shared the room and shared the bed as well. And the unsafe practices mainly reflected unsafe the bed sharing with the mother. So this is something which is very culturally driven into many of our communities, because we always feel the baby is safe only if the baby is alongside us. So this is something that needs to go into the community, that the baby can be there with the mother in the same room, but still has to be in his or her own bed. That is one. The second thing when I went through the literature was, essentially, though there has been 3 updates to the safe sleep recommendations, that is 2011, 2016 and 2022, essentially they carry the same information. It's only the strength of recommendation that has been changing over this. But I'm not sure whether healthcare workers are updated on these. And I think because the healthcare workers seem to play a very pivotal role in maternal adherence to the safe practices. So I feel even though there are several recommendations time to time, the message should go to the healthcare workers that it is essentially the same, but what we see is an increasing evidence for following these practices. So I thought these are the 2 things that need to be addressed. In fact, I submitted to a UK journal, and in UK they permit room sharing and bed sharing. Their policies are different. The American policies are, the AAP policy is no room sharing, no bed sharing. Room sharing, no bed sharing. But however, the British, they accept room sharing and bed sharing. So this was another thing I had to kind of, when the revisions came, I had to work on.
Thank you.
Yeah, thank you.
So just a quick comment as well on the room sharing and bed sharing, because a very famous comment that we'll get is it's easier to breastfeed, right? So yes. I just, take out the breast and turn, baby's right there. So if you want me to exclusively breastfeed for 6 months, then room sharing for me is an easier way to go. How would you, though, from a public health perspective, address the issue of parents who don't have cribs or bassinets or anything to put the baby in? Because when we ask questions at the point of discharge, again, a common question and common answer is, we don't have a crib, and therefore we co-share beds.
Yeah, so that is why one of the recommendations was even we need to provide resources to the mothers. These cribs are all expensive. Actually the commonest practice, unsafe practice, was keeping the baby in the car seat. So I think the resources have to be provided to the mothers, especially those who are Medicaid beneficiaries for crib. And another thing is, in the 2022 AAP recommendation, they are more accommodative about bed sharing, little more accommodative about bed sharing, especially if the mother dozes off when breastfeeding. They say it is still safer.
Correct, and bed sharing may be preferred in the absence of instead of putting the baby in the car seat. Yes. Some other cultural things that we've noticed is that sometimes the chest of drawer is actually utilized as bedding for the baby, or even a cardboard box that is bedded. So it's a lot to discuss, but I think a lot of education and investment from a public health perspective will improve safe sleep initiatives.
Thank you, thank you.
Okay, thank you, and thanks for new collaboration. Okay, next we have Nita, who is going to present a health survey from Kenya on socioeconomic and socio-demographic inequalities in the continuum of maternal health care utilization.
Good afternoon, everyone. My name is Nita Clarice Akech. I am a biostatistician by profession, but I work as an admin in the research center. And I'm also a health researcher, and my research interests lie around maternal and child healthcare utilization, as well as mental health among adolescent girls and young women in low to middle income countries. So thank you for this chance to present my work. This is something I've been working on for the last few months. And my project is on the socioeconomic and demographic inequalities in the continuum of maternal healthcare utilization, with insights from the 2022 Kenya Demographic Health Surveys. So maternal mortality is a major global health concern and a key indicator of health system performance and equity. There's an estimated 287,000 maternal deaths globally, with over 90% of these deaths concentrated in low to middle income countries, particularly in sub-Saharan Africa. And most of these deaths are preventable through access to essential services such as antenatal care, skilled birth attendance, and postnatal service utilization. So a lot of women attend at least one antenatal care visit, but very few of them end up achieving the recommended number of antenatal care visits, have skilled birth delivery, and have timely postnatal care attendance. And these drop-offs are critical, as the failure to attain a complete continuum of care is associated with adverse maternal and child health outcomes. In Kenya, maternal health outcomes have improved. However, there's a significant gap still remain in ensuring the continuity of care. So this study examined the socioeconomic and demographic inequalities in the continuum of maternal healthcare utilization using the nationally representative Kenya Demographic Health Survey. So the main objective was to examine the socioeconomic and demographic inequalities, but we also looked at the prevalence of no, partial, and complete continuum of maternal healthcare utilization. In addition, we also looked at the key inequalities in the continuum of maternal healthcare utilization. So this was a secondary analysis of the Kenya Demographic Health Survey that was carried out in 2022, and we focused on women who were aged 15 to 49 years who had a live birth 5 years preceding the survey. And our total weighted sample was 13,612 women. And the primary outcome for this project was the continuum of maternal healthcare utilization, which was assessed using the three main indicators, that is antenatal care. Antenatal care meaning women who attain 4 or more ANC visits during the course of their pregnancy, skilled birth delivery, that is delivery by a midwife, a nurse, or a doctor, as well as postnatal care utilization 48 hours post-delivery. And we combine these three into a composite indicator to form the main outcome variable called the continuum of maternal healthcare utilization, which had three categories: either no, meaning women did not access any of the three services during the course of their pregnancy; partial, to mean they utilized one service but not all the three services; and complete, to mean that they utilized all the three services over the course of their pregnancy. We did a bivariate analysis, and all the significant variables were carried on to the multivariate analysis, where we did a multinomial logistic regression. So descriptively, 77% of our women were in union. More than half of them had a secondary education or higher, and 60.7% of them belonged to or resided in the rural area. So looking at the prevalence of the continuum of maternal healthcare utilization, only 36.6% of the women achieved complete continuum. More than half of them only utilized partial continuum, and 2.7% of the women did not utilize any of the 3 services at all. So in our bivariate analysis, all the variables that we used were significant, and we included them in the final analysis, in the multinomial analysis. And we can see some of the findings were education, residence, pregnancy intention, and wealth quantile were the key contributors to completion of continuum. Then the multivariate analysis, we can see that wealth and education were some of the greatest predictors of the completion of continuum. Women who had a higher education, secondary or higher education, were highly likely to attain complete continuum. Women who belonged to the richest wealth quantile were also highly likely to complete continuum. Women who had a planned pregnancy as well had a higher likelihood of completing continuum. Inversely, looking at birth order, multiparous women were less likely to achieve a complete continuum. So what does this mean? So while utilization of maternal healthcare services is high, the completion of continuum remains suboptimal with evident inequalities across socioeconomic and demographic groups. Only that 6.6% of the women achieved complete continuum despite relatively high individual service uptake, highlighting that there are critical gaps in between antenatal care, delivery, and postnatal care stages. Wealth and education were some of the strongest predictors, consistent with similar studies that have been carried out in other sub-Saharan countries, in India and in Afghanistan. And these reflect on the structural barriers requiring equity-focused interventions. Planned pregnancies were equally associated with completion of continuum, suggesting intentional, consistent health seeking rather than fragmented approach over the course of their pregnancy. Media exposure was equally positively associated. Media disseminates health information and shapes health-seeking care behaviors, especially for women from underserved communities. And then higher birth order equally reduces utilization. Multiparous women rely on prior experience and face competing responsibility, making them to perceive themselves at a lower risk over the course of their pregnancy. So this study, some of the strengths of this study is the fact that this study utilizes a nationally representative survey, ensuring a high external validity, and then the use of a composite measure, looking at combining the 3 aspects into one, provides a more holistic assessment of health performance rather than traditional single-point indicators. Some of the limitations include being a cross-sectional study. Cross-sectional study design precludes the establishment of definitive causality, and the fact that this data relies on self-reported history of births occurring up to 5 years prior and may be subject to recall bias. So in conclusion, while the country has attained a relatively high engagement with individual maternal healthcare services, the continuity of care is suboptimal and deeply fragmented. For it to achieve equitable outcomes, the country requires a systematic shift towards ensuring that the most vulnerable populations, particularly the poor, the uneducated, and multiparous, can navigate the maternal healthcare continuum without any interruptions. Only through targeted and equity-focused interventions can the country accelerate progress towards national and global health mandates. Thank you.
Thank you very much. Questions?
Thank you, Nita. I have a question focusing on what is the most of people or outcomes in your study lacking at least 1 or 2 of the services.
Pardon?
So my question is, your outcome was a composite one.
Yes.
Made of 3 different elements. Which of those was the one that lacked most often?
So the one that was mostly missing for most of the women was postnatal care utilization. Many women will initiate ANC, they will deliver at a facility, but they end up dropping off at the point of delivery. So there is a gap between delivery and postnatal care utilization.
Because maybe that can show where the need is the most, right?
Yes.
Thank you for your excellent presentation. Just for clarity, antenatal care, is it free of cost or subsidized?
In Kenya, it is free of cost.
Okay, and in terms of your indicator or the use of 4 visits or more as being adequate antenatal care, for us here, we actually use greater than or equal to 8 visits as being adequate. What was your reference point for using 4?
So currently the WHO recommends 8 visits. It is even in Kenya, but at the point of this study, the DHS was using 4 or more contacts as a reference point.
Okay, and just to compare, so here in Antigua and Barbuda, we actually have just about 30 to 35% of our women either having minimal or no antenatal care. And it is yet to be formally studied, but anecdotally, the reasons include, similar to what you would have mentioned, the multiparous women. We've done it before, we know how it goes, we don't need to go. The whole issue of, even though healthcare from an antenatal perspective is free of cost, persons' long wait times at the district clinics is a concern. Even confidentiality has been expressed as a concern where I may have a particular chronic illness and I don't want persons, the community nurse, to be aware because others may become aware. So those are some of the things that we've noted. And then for those who may opt to do care privately, financial constraints. So it would be interesting to see what could happen to then shift your indicator from 4 visits and more to actually the WHO standard of 8 visits and more. But excellent work.
Thank you.
Yeah, can we just stop here because 3 more presentations? Quick. If it's quick, yeah.
Okay, so if care is free, how did you explain that the wealthiest report more visits? You see higher visits from the wealthiest, and then the other was like collinearity between wealth and education. Can you comment on that?
Okay, so in terms of wealth being accessible and free to everyone, women from the poorest categories still have issues accessing healthcare, not majorly because of financial barriers, but probably because of lack of well-established health facilities, or maybe the distance from healthcare facilities, or lack of healthcare workers in these various facilities for this to be able to happen.
So SDOH kind of infrastructure, is that what you're talking about?
Sorry?
Social determinants, other social determinants of health, is that?
Okay, thank you very much. Now let me invite next speaker, Dr. Tarun. He's going to present his post-COVID survey data, which was done in AUA with students. It's on stress, mental health, and adaptation among medical students during educational disruption due to pandemic, a mixed method study.
All right. Thank you, Dr. Persana. Thank you all for being here. Welcome. I went way over time last time. This time, I'm going to make sure that I don't do that. So, good afternoon. I'm Dr. Taryn Kalki. I'm Assistant Professor in the Education Enhancement Department at AUA. I have 8 minutes, so today I'm going to attempt something that is quite unnatural for me, discipline. I'm presenting our recently published Frontier in Education study on stress, mental health, and adaptation among medical students during pandemic-era educational disruption. It's a mixed method study, and the story begins with one question. When disruption hits a medical school, who gets hit hardest? Here's the puzzle that motivated this study. When educational disruption hits a medical school, whether from a pandemic, natural disaster, or anything that breaks the normal rhythm of training, institutions naturally ask, who is most vulnerable? The instinct is to look for subgroups, earlier semester students, students without prior online learning experience, or specific demographic groups. And that makes sense. Targeted support feels efficient. But we asked a slightly different question. What if the disruption is not concentrated in one subgroup? What if it's broadly shared across the cohort? And that's what we set out to examine. Let me show you how we approached it. This was a cross-sectional convergent mixed method study at AUA, focused on Med 4 and B6 students who had experienced both online and in-person learning during the pandemic. We had 133 consenting respondents from a target population of 400. The instrument was a 21-item study-specific Qualtrics questionnaire pilot tested with 15 students. The 6-item challenge subscale showed good internal consistency with a Cronbach alpha of 0.87. Quantitatively, we looked for associations, correlations, and underlying structure. Qualitatively, we analyzed open-ended responses to understand what those patterns meant in the students' own words. The sample was 133 preclinical students, mostly Med 4 and BSIC. The key point is that these students were still before the full clinical clerkship phase, which matters when we talk later about limited clinical exposure. The cohort was 55% female, about half had prior online learning experience, and a substantial portion were over the age of 25. For demographic comparisons, we restricted analysis to Med 4 and BSIC. Students rated 6 core challenge severity items on a 1 to 5 scale. Limited access to clinical settings stood out, with a median of 4. Everything else clustered around 3. Workload, time management, mental health, face-to-face interaction, and technical difficulties. So the burden was broad, but clinical access was the clearest pain point. That raised the next question. Where were these burdens? Were these burdens concentrated in specific student groups or broadly shared? I think I already answered this, but this is a central finding. We tested 11 associations between student characteristics and reported outcomes, semester, gender, age, and prior online experience across academic performance, teaching satisfaction, isolation, financial challenges, health concerns, and perceived long-term effects. Every test, unfortunately, was non-significant. The smallest p-value was 0.127, so we did not find evidence that the burden differed systematically by age, gender, semester, prior online experience. The disruption appeared broadly shared across the cohort. But, and this is where it gets interesting, the challenges themselves were strongly interconnected. Lack of face-to-face interaction correlated with well-being strain correlated with difficulty balancing workload, technical difficulties correlated with mental health challenges. So these were not isolated complaints. They behaved more like a connected disruption syndrome. That raised the next question. If the challenges are this interconnected, is there any underlying structure? Factorability checks supported conducting exploratory factor analysis. KMO was 0.88. Bartlett's test of sphericity was highly significant, so the data were appropriate for factor analysis. When we analyzed 8 disruption-related variables, the 6 core challenge items plus transition stress and academic performance impact, 2 factors emerged, explaining 59% of the variance. Think of factor analysis as systematic eavesdropping. We ask the data which questions are students answering as if they belong together. The blue bars represent factor 1, self-regulation and well-being. These were personal adaptation challenges, academic responsibility, time management, mental health, and adjustment to online learning. The orange bars represent factor 2, a narrower structural and logistical domain anchored by limited clinical access with smaller contributions from related logistical items. So the disruption was not one single problem. It separated into two domains that students had to manage internally and what the institution had to provide externally. Now let's see how the qualitative responses fit this picture. The qualitative responses put a human shape on the quantitative pattern. We formally analyzed 2 open-ended items, 58 responses on adaptation strategies and 52 on limited clinical access. 4 themes emerged: disruption of learning structure, limited clinical exposure, emotional strain and coping, and need for flexibility. Students described losing routine, feeling less confident clinically, struggling with isolation, and relying on peer support. Recorded lectures and self-paced options to manage the disruption. So the qualitative data echoed the same 2-domain structure: personal adaptation and institutional barriers. Here's the integrated picture. Quantitatively, the challenges were broadly distributed and clustered into 2 domains. Qualitatively, students described what those domains felt like: broken routines, reduced clinical confidence, emotional strain, and the need for flexibility. So the numbers gave us a pattern, and the voices gave us the lived texture of that pattern. Limitations, very briefly. 4 limitations: single institution, study-specific instrument, retrospective cross-sectional data, and a sample below the target needed for a 5% margin of error. So the findings are exploratory and context-specific, not confirmatory. What this means for institutions practically: if the disruption appears broadly shared rather than concentrated in specific demographic subgroups, the institutional response should not rely on triage. It should start with universal design. Baseline support should be built for the whole cohort, with targeted support layered on where needed. 3 implications follow. First, address both domains. Personal adaptation matters, self-regulation, mental health, and workload management, but structural barriers matter too: clinical access, reliable technology, and opportunities for interaction. Supporting one without the other leaves the problem half solved. Second, make flexibility the default, not the exception. Students explicitly valued recorded lectures, self-paced options, and structured peer connection. These are scalable supports that help students manage time, stress, and uncertainty. Third, design for the whole cohort. These findings suggest that during broad educational disruption, institutions should not wait to identify the at-risk subgroup before acting. The disruption appears broadly shared, so the first-line response should be broadly available. To wrap up, to sum up, disruption appeared to affect medical students broadly, not selectively. The challenges clustered into personal adaptation and structural barrier. For institutions, the implication is universal design as the baseline, with targeted support layered on where needed. My sincere thanks to my co-authors and Dr. Honavar for inviting me onto this work and encouraging this presentation, and to the students who participated, and to AUA, and for all of you here. Thank you.
Thank you very much. Due to short time, we will continue with the next presenter. No, on time. On time. For what? This time on time. Okay, let me call Dr. Rick. So you have 5 minutes. So he's going to present on role of GERG2 channels in morphine-induced metabolite changes.
Taryn? Discipline is not my middle name. But we have people out here. My chair, I know, is here. And is she here? Or did she leave? Dr. Ravi, are you here? I know they have a bet going on whether or not I can do it in under 8 minutes. 7. Now it's 7. Okay, I don't know. There's 100 EC riding on it. So, What are GERK channels? So GERK stands for G protein coupled inward rectifying potassium channels. Now, people are normally used to thinking about the delayed rectifier potassium channel that brings the action potential back down to resting membrane potential to maintain excitability. That happens in milliseconds. Notice I said milliseconds. Yes, you didn't know, but a whole unit of measure of time was named after me. I'm not just another pretty face. Now, over a long period of time, seconds to minutes, we have a brake system, which are the GERK channels in the brain. And the GERK channels are implicated in analgesia and addiction, especially to opiates. And so, this is an NMR spectroscopy study that I did in my lab at Howard University Hospital. Dr. DeCordy is the primary author. We just published this in 2026, and she took over my lab, and I'm still obviously working with them. Dr. Wang is the chair of the nuclear medicine department, and the other people are pharmacologists and neurologists. So it takes a big team. It's intensive work to measure brain metabolites in a living animal. Anesthetized but living brain metabolites in real time is not a thing that people can do very easily. So our interest is morphine here, and morphine is the most prescribed drug for analgesia, very strong analgesia, and everybody clinically knows there's a problem with morphine, that if you give it at high doses, long periods of time, even short periods of time, it turns to hyperalgesia. So it'd be very nice if we could knew why it turns to hyperalgesia and find some targets that we can target to keep the analgesia and avoid the hyperalgesia, which makes the pain much worse than even in the beginning. So we're looking for the molecular break. Now, morphine in the neuron that is transmitting the pain impulses attaches to the morphine receptor, and these GERK channels, G protein coupled inward rectifying potassium channels, hyperpolarize and quiet everything down. Over a long period of time, it stabilizes things, and so it works very well. Now, the GERK channels, as we said, are the brain's brake system, but it doesn't only work in the neurons, it works in the nucleus accumbens, the reward center of the brain, so it's involved in addiction. In other words, the GERK channels are responsible for actually hyperpolarizing neurons that release dopamine in the nucleus accumbens, as well as in the respiratory centers. One of the big problems with morphine is what? Or any opiate is what? Respiratory depression. So we have addiction, we have respiratory depression, and we have hyperalgesia. And we think that GERK channels are involved in all three. So wouldn't it be nice if we can find a metabolite signature in the different parts of the brain that we can target to make a better opiate, an opiate that doesn't produce hyperalgesia, doesn't produce respiratory depression, and doesn't cause addiction? Well, that would be very nice, and I'd like to have the patent on that drug. So this is what we're after. In this study, we're just after determining where that switch is. And we think the switch is in the medulla, in a place called the RVM, the rostroventral medial medulla. There's a gate, and the gate consists of on cells and off cells. So obviously, morphine is going to stimulate the off cells, we think, to cause pain to turn off, right? And if those aren't working, you get hyperalgesia. So on cells, if they're stimulated, you'll get more pain, and the analgesic effect won't work. So we think that there were GERK channels in this site. Well, we were able to identify not only the site in this part of the medulla where we think the gate exists, but then we were able to purchase a mouse that had half the normal functionality of GERK channels. Now, we can't get a homozygous knockout mouse The homozygous knockout mouse would have no GERK channels because that would be a lethal mutation. That's how important the GERK channels are to life. So we have a heterozygous knockout with half the normal functionality. And the experiment consisted of acclimating the animals for 3 days. That means we play with them a little bit. Then we do a baseline scan, an NMR spectroscopy scan, and we find the right voxel. We can actually hone in on this in a mouse. And the voxel was in the RVM, as I told you, the place we think that gate exists. Then we implant pellets. And the pellets were implanted, subcutaneous pellets of morphine, and then we rescan them 5 days later. Now, the dose of morphine we use is shown in the literature to be an addictive dose. So here's what it looks like in the wild type, the normal mouse with 100% functionality of the GERK2 channels. These are the metabolites we looked at: phosphocreatine, glutamine, glutathione, taurine. Phosphocreatine is a measure of energy balance. So if we look at over on the right, if you see what's happening, the summary shows that energy is being stored because phosphocreatine is increased. Well, if energy was being used up, phosphocreatine would be depleted. The glutathione, the taurine are antioxidant defenses, and of course, glutamine, glutamate, and GABA exist in a cycle of neurotransmitters that are very important at this site. So this is what it looked like in the GERK2 mouse compared to the wild type. We see energy storage response was blunted, the glutamate cycle changed, the NAA, N-acetyl-aspartate, is a metabolite that tells us about neuronal integrity, and the antioxidant system actually ramps up. So it tells us that there's a different signature at this gate in the RVM in the wild-type mouse compared to the GERK2 less functional mouse, and it suggests to us that we have found a site where metabolite differences may make a difference, and it might be a switch between analgesia and hyperalgesia. What we don't know is, in the GERK2 mouse, would he be experiencing analgesia or hyperalgesia? That will require behavioral studies that we're planning to do in the future. And why does it make a difference? It makes a difference because, as I said earlier, if we can target the GERK2 channels and find out really what they're doing, we might be able to take the first step toward a safer opiate, a more effective opiate with analgesic effects without hypoxia and without the high in addiction we know that complicates the use of morphine over a long term. Peace out. Thank you very much. 8 minutes?
Thank you.
8 minutes? 9 minutes? No way. Don't tell them I'm going to owe them money.
Okay, no questions. You want to ask question?
Just one.
He will take another 5 minutes.
He likes to put me on the hot seat. Go on.
Okay, just one. Yeah, just yes, no question. All right. So, like as you said, once you block, knockout mice with this GERK channel, right? So we saw that there was no changes in those metabolites, and as we know, morphine we have seen like hyperalgesia. How this hyperalgesia is different from when you give a blocker like naloxone, because same thing can be expected when you're morphine.
We don't know. We have to do behavioral studies, but it's probably the same thing. I mean, hyperalgesia is hyperalgesia. There will be no difference other than the mechanism and the site might be different at which you're targeting it.
Yeah, I think that would be very interesting to find.
Yeah, compare the GERK2 with morphine and with naloxone too.
Right.
Do all of that. I agree with you.
Yeah, that's the next project.
Let's do it.
Okay, thank you. So, our last presentation, That's poster presentation by Sparkle Tong. It's 4 minutes.
Good afternoon. My name is Dr. Sparkle Tong. I am a recent AUA grad, and I am working currently in the EED department as a teaching fellow. And today I will be discussing the case that I worked on during my clinical rotations, and it's entitled Bloody Phenomenon, a rare case of hemophilia from cystic artery hemorrhage following percutaneous cholecystostomy. So hemophilia is defined as bleeding within the biliary tract, and although it's rare, it can lead to life-threatening situations. And it encompasses the Quincke's triad, which includes obstructive jaundice, upper GI bleeding, in addition to right upper quadrant pain. However, it's only seen in less than 40% of cases, which makes this diagnosis delayed and often leading to delayed challenges. So the main importance of this case is to show that there is an increased use of percutaneous cholecystostomy, especially in patients who are critically ill and cannot undergo surgical procedures for cholecystitis. And so this can lead to delayed vascular complications, to include cystic artery hemorrhage, which can often be rare and under-recognized. So we present with this patient who is a 72-year-old man with a complex cardiovascular and metabolic history, and he presented to the ED initially for the management of cholelithiasis, to which he had an ERCP as well as a CBD stent placed. And however, his course was disrupted by perihepatic collection, to which a percutaneous cholecystostomy tube was inserted. 3 weeks later, he then presented with bloody output from this cholecystostomy tube. Interestingly enough, his only complaints was right upper quadrant tenderness with no gastrointestinal signs of bleeding, such as hematemesis or melena. And so, with that concern, a CTA was done, which showed a contrast extravasation from the right placed hepatic artery, which is a branch of the cystic artery. It further showed evidence of gangrenous cholecystitis in addition to a migrated biliary stent. Now, the importance about this is that the right placed hepatic artery is a critical finding of an anatomic variant, meaning that because of this increased complexity, endovascular procedures can lead to increased risk for hepatic ischemia. So, with that emergencies done, we had to do an angiogram with a stent placed because transcatheter embolization could not be done due to the right replaced hepatic anatomy. The patient was then had a stent placed once the angiogram procedure was done and was managed in the ICU for fluid resuscitation, IV antibiotics, and serial management. Once he was clinically stable, he was able to later be discharged with the hopes of getting elective cholecystectomy done later on. So the teaching point of this case is to understand that when patients are presented with bloody output from a cholecystostomy tube, we must have emergent concerns for hemophilia, even though with the absence of the triad, because it can falsely reassure clinicians, as in this patient, he had no signs of gastrointestinal bleeding and also no signs of jaundice. So instead, we must have prompt recognition, timely CTA, according to our various success in endovascular management. This case also highlights the importance of multidisciplinary coordination with the use of interventional radiology, gastroenterology, surgery, and critical care, able to provide a timely manner in this life-saving procedure for this patient. Also, it is important to note that how to manage hemophilia is normally first line through transcatheter embolization. However, in this case, we used the use of the angiogram with the stent placement. And the definitive management would be elective cholecystectomy. So to conclude, Hemophilia for percutaneous cholecystostomy is rare, but it's a high stakes in diagnosis. An early suspicion, rapid CTAs, and recognition of vascular anatomies can be a life-saving management for persons presenting with this phenomenon. This case challenges physicians to look beyond classic presentation of hemophilia and recognize that in a high-risk patient, blood in cholecystostomy tube may be the earliest and most life-saving diagnostic clue. Thank you very much. And if you're interested in taking a more read about this case report, you can scan this QR code, which gives you more details. Thank you very much and have a good day.
Thank you, Dr. Sparkle. Thank you, Dr. Akinya, for giving me tough task to moderate faculty. Now I will hand over to Dr. Leslie.
Before we start the next segment, I would like to acknowledge before everybody my two right hands that have helped me organize this wonderful meeting. The first one, you heard her present, Nita Kesh. And the second one, Dr. Pamela Linares, our faculty and resident biostatistician from the center. They have been great help. Now, Dr. Walwyn.
Good afternoon, everybody. Welcome to the last section for this afternoon for what's been a very successful research day. So without further ado, I'm going to invite Dr. Sherry Tulloch. Is Dr. Sherry Tulloch here? Here's Dr. Tulloch. And Dr. Tulloch is going to discuss with us HPV-based screening in the Caribbean, opportunities and challenges. Please welcome Dr. Sherry Tulloch. Are we able to put her presentation on the screen, please? That's not it.
Just hover. One second.
Okay. Yeah, no worries. Good. Hello, good afternoon, everyone, or good evening, and thank you so much to the organizers for giving me this opportunity to share on this topic. So we're going to speak about HPV-based screening, the opportunities and challenges. I have no disclosures. And the reason we're speaking about this is because cervical cancer is the fourth most common cancer affecting women globally. And in low and middle income countries, we have a higher incidence and mortality rate. 95% of these are caused by high-risk HPV. Now, as you can see on this graph, in the Caribbean, we have a higher mortality and incidence rate compared to the world average, with only about 2 of our islands being below the world standard. So the WHO has come up with a formula for us to eliminate cervical cancer as a public health concern, and that is through the 90-70-90 targets, which includes screening 70% of our women by the age of 35 and again by 45 with a high performance test, which in this case is HPV testing. Now, if we look at Antigua and Barbuda, prior to 2021, you'd see that we were screening less than 50% of our target population, and that was cytology based, and 87% of the screening was taking place in the private sector. This is not out of keeping with what is happening in our region, where unfortunately only 35% of our countries are meeting that 70% target that we spoke about previously, and most of them are doing cytology based. And so the answer to fixing that problem is transitioning to HPV-based testing. Now, this is a prescribed approach by the WHO, where we use HPV testing and we triage those that don't have type 16 and 18. And the reason why 16 and 18 is separated is because HPV type 16 and 18 cause 70% of the cases of cancer that we see. Now, to make matters worse, the WHO updated their guidelines about 2 weeks ago, which basically means that where we would have had cytology triage previously, we have no, they actually recommend visual inspection with acetic acid and colposcopy over cytology, which means that we're going to see an increase in our workflow and demand for high system performance if we're going to be effective. Now, we put this in the context of the Caribbean. The Caribbean tends to have a higher HPV prevalence rate compared to the world, the rest of the world, where it tends to be about 10 to 12%. We see figures looking more like 20% or higher in our region. And this is really the point. This is the continuum. When we talk about screening and treatment to prevent cervical cancer, we do HPV testing to identify who is at risk now. And then based on the triage test that we use, we're trying to predict who is more likely to have changes in their cervix, which we call high-grade changes, and which one of those women require treatment now. And so when we look at the challenges in our region, we see that we have issues with identifying our target population, policy development, treatment, quality assurance, and professional training, protocols, and information and education. So this brings us to our first opportunity, which is system investment and development. And this is just a snapshot of what Antigua has done in this regard. So the first thing is that we had a tremendous amount of international collaboration with the Pan American Health Organization being at the forefront of that, supported by the Basic Health International and the International Agency on Research in Cancer and the International Gynecologic Cancer Society. So we are where we are because of that, and that was an opportunity for us. We also used the opportunity once we introduced the HPV testing to, of course, have training. So all our nurses, all our doctors were trained in using not just HPV testing, but colposcopy to standardize our approach and to ensure that we had both internal and external quality assurance. We looked at our screening services, and we reorganized our screening services, including having a dedicated team to cervical screening, and we expanded our colposcopy services. We established our first ever national guidelines, and then we went on to, we've gone on to invest more in the electronic health record system and see how much we can leverage technology. So this is just a snapshot of our guidelines, which are now completely HPV primary based. And this is just to show you that we have reorganized our service to deliver HPV testing. And what we found is that we have a 21% high-risk HPV positivity rate. So 21% of our women will require further treatment or follow-up. Now, prior to HPV testing, we were doing perhaps, and this is just looking at our figures, we did about 100 biopsies of women who were screened positive based on cytology. And when we did those, we saw that a fifth of the women that we were biopsying actually had no changes in their cervix. And we're picking up a lot of low-grade lesions, which are not the women that we worry the most about when we're thinking about who's going to get cervical cancer. And only 30% of the women that we were biopsying actually were women at risk of developing cancer. And so when we moved to HPV testing, not only did we double the number of women that we were able to enroll in our colposcopy services in half the time period, but we also were better able to pick up the women who are truly at risk, which are women who have high-grade lesions. As you can see here, this just looks at the time indicators. And I would like you to, if you pay attention to the first line, you see that women were able to get their results in an average, a median of 18 days. And the time between doing their test and getting treatment was 135 days for women with HPV 16 and 18 who would not need a triage test. But it was almost 60 days longer for persons who needed a triage test. So that was a challenge that we had. And as you can see on this, half of the women that we biopsied required treatment because they had high-grade lesions or they had cancer. So that's significant. That's a significant burden in our colposcopy clinic. Now, we could actually eliminate some of that time if we could actually offer treatment up front when we saw the women the first time. But that would mean that we would have to be very accurate in our colposcopic impression of what is taking place at the cervix when we see them. But as you can see on this, we only get it right about 70% of the time. So that brings me to our second opportunity, which is smarter screening through technology, which I'm just going to run through in a minute. And that is using AI, which we've been hearing a lot about. And AI is really just learning from the data that we do have and using that data to help us make more accurate decisions. It can strengthen our health system resilience. It facilitates task sharing with persons who are not necessarily as skilled as those who are skilled. And it enables us to make data-informed policy changes through analytics. But it's important that we're actually collecting accurate data if we're going to be using AI. So this is just an example, data journey mapping, where it's a process of basically capturing every patient healthcare provider interaction and collecting data at each point. And that creates these data hotspots. And then using that data now, you can then use AI models to optimize your approach and be more efficient. So you can look at cluster analysis to see maybe who is getting most of the HPV infection, where you need to focus your campaigns, and you can actually plan your treatment better. And this is just a study, a meta-analysis that showed that AI outperformed both triage testing, which is cytology, as well as colposcopy in identifying women who had high-grade lesions and needed treatment to prevent them from developing cervical cancer. And this is just us here in Antigua already seeing how we can benefit from this technology. And so in conclusion, HPV-based screening is our path to cervical cancer elimination, but it does increase the demands on our healthcare system. And so, but it also brings opportunities to strengthen our services, and AI can help us to basically bridge the gaps where cytology and colposcopy fall short. And the Caribbean must drive, we need Caribbean data, to drive Caribbean approaches in screening and cancer prevention. Thank you.
Thank you very, very much, Dr. Tulloch. And without further ado, in the interest of time, we're going to move on to our next presenter. So we are going to invite Dr. Siobhan Bell-Jarvis to come up and show us about the roadmap to zero leprosy, a situational analysis of the Guyana model. Please welcome Dr. Bell-Jarvis.
Any assistance would be appreciated.
So good afternoon to our online and sitting audience at this time. It's indeed a privilege for me to present, and I thank the organizers for allowing me to do so. So I have no disclosures, and I'm happy to present on the Roadmap to Zero Leprosy, a situational analysis of the Guyana model. I'm not sure how many of you have seen leprosy. Many persons sort of attribute it to the Bible days, but leprosy actually occurs in more than 120 countries worldwide. It's one of the 20 neglected tropical diseases that the World Health Organization has earmarked for prevention, elimination, and eradication. And still to date, we have just about 200,000 new cases of leprosy detected each year worldwide. The cases have actually been reported across all 6 regions of the World Health Organization. I'm not sure if we're aware, but St. Lucia actually has had a resurgence of leprosy. In 2025, St. Lucia actually had 16 cases of leprosy compared to 2023, where they had 11, and prior to that, they had 2 cases. So although this is something that is curable and interruption of transmission is possible, it continues to evade several countries. Why is that so? Leprosy is not really thought to be a public health problem. There's reduced research interest, and many healthcare providers have not seen leprosy. I can tell you, before I went to Guyana, I had never seen leprosy. I'd only seen it in the textbooks. And so elimination of leprosy as a public health problem was actually a target endorsed in 1991 by the 44th World Health Assembly. The aim really was to have a registered prevalence of less than 1 case per 10,000 population. This was actually achieved on a national level in 2015. And in 2022, Guyana, and I'll explain why Guyana is a country of interest, actually registered a prevalence of 0.56 cases per 10,000 population. However, leprosy still has not been eliminated to date. WHO therefore envisions several targets by 2030. We need to see 0 new autochthonous cases, which means no indigenous cases, a 70% reduction in annual number of new cases detected, and a 90% reduction in rate per million population of new cases with grade 2 disability. And so on this background, we recognize that there is a roadmap to elimination. So phase 1 really is where you have no new cases among children for at least 5 consecutive years. Phase 2, you're actually interrupting transmission until elimination of disease. And phase 3, you have post-elimination surveillance. And then you get to the non-endemic status. So when we look at it now, WHO actually presents a very ideal framework, but when you're on the ground, it really is far from ideal. And therefore, in order for me to achieve the practicum for my public health, my master's in public health, I opted to use an actual country model to help to analyze what's happening with leprosy elimination. It will enable a SWOT analysis, and it would also facilitate optimizing elimination programs without having to experience pitfalls in other countries. In 2022, which was mentioned before, Guyana had a prevalence of 0.56 cases per 10,000 population. And so basically, I observed the program of the Guyana Leprosy Elimination Program. Through consent of the Chief Medical Officer of the Ministry of Health, a learning agreement was prepared, discussed, and established, and policies, practices, and the legal framework were explored, healthcare workers were observed, and standardized forms were utilized for interviewing of staff and reviewing the surveillance reports. Just a bit of background, this doesn't project well, but in Guyana, which they have a population of just about 850,000 persons, 10 districts, they had a leprosarium in 1958. They subsequently moved on to having a public health skin clinic, and then now they're actually doing a single dose of rifampicin campaign as of 2022, and they also have an electronic database. So what were the findings based on examination of their program? There was no national strategic plan, although there was a policy in place. Political will was present. PAHO helped to build capacity. They had surveillance, but there was no surveillance or monitoring rather for antimicrobial resistance and no pharmacovigilance as it relates to the management of leprosy. They had a contact tracing system in place, however, consent was required. They introduced the preventative chemotherapy program in 2022, and active case finding remained dormant because Guyana is quite big. As we said, it's 10 districts, 850,000 people, sometimes 1 vehicle, so it's very difficult to get out to the varying districts. And then we look at access to referral centers that was present. They were able to manage reactions to drugs. Self-care and mental health care was available. However, the stigma was significant. If someone knew that I had leprosy, they wouldn't eat from me. They wouldn't come to my store. They wouldn't trade with me. and so persons opted not to reveal their status. We also recognize that even business places didn't want to employ persons who were diagnosed with leprosy, and so it caused significant challenges in terms of the overall management. Multi-drug therapy also caused side effects, so it causes the skin to be dark. So there's a challenge with compliance, because once persons saw anyone with dark skin, then they knew that they were on MDT and therefore would try to stay away. And then social support was a challenge, where persons had grade 2 disability and were not supported. This is a quick extract and significant numbers to note. Annual cases detected, we noticed from 2015 to 2023, not much difference there except in 2020 where they had 13 new cases, and that's likely because of the COVID-19 pandemic. The new case detection rate, 3.44 per 100,000, we'll have the international reference, but that translates to 34.4 per million persons. Look at the number of children. So between 2015 to 2023, each year you had varying from 1 child to up to 7 children being diagnosed as new cases of leprosy. And 2020 is a false underestimate because, again, COVID-19. So we can see that leprosy is very much present in Guyana. And look at the persons presenting with disability. Thankfully, from 2016, where you have 19 persons presenting with severe disability, coming down to 8 persons, seems to have had some improvement in terms of the timeliness of detection. So quickly on discussion, pediatric cases continue to be diagnosed over the past 9 years. Remember that we said in the framework of elimination, you have to have 0 childhood cases consecutively for 5 years. It therefore means that, unfortunately, Guyana will not reach the 2030 target of eliminating leprosy. The diagnosis of leprosy within the pediatric population, however, suggests recent transmission. It therefore highlights that they have an efficient diagnostic system. Diagnosing grade 2 disability amongst new cases suggests delayed diagnosis, but this has been improving. And the annual new case detection rate is of concern because it's 34.4 per million. If we look across the regions globally, we recognize that we have new cases at a rate of 18 per million population in Africa to a high of 70.4 per million in Southeast Asia. So we can see with Guyana being at 34.4 per million that they're basically number 2 on the list. So strengths, they had a policy in place, but no national strategic plan. The SDR prophylaxis was in place, they had a mobile clinic, but they had several opportunities, significant research gaps, differences between male and female, also capacity building across regions of the country. They had several weaknesses in terms of having a paper-based system, no social worker on staff. Leprosy awareness was primarily on Leprosy Awareness Day and not throughout the year. And several threats. The pandemic threatened their ability to consistently detect cases. So recommendations, they really should expedite regional mapping, have formal transportation to enable them going to the districts, strengthen their water, sanitation and hygiene program and campaign, have continuous awareness, and have multi-stakeholder partnerships, amending legislation. Blanket prophylaxis should be considered in endemic regions, and by blanket prophylaxis, we mean giving everybody in that region that single dose of rifampicin, enhancing accessibility to mental health support. So just locally in Antigua and Barbuda, leprosy is a notifiable disease. The medications are covered by MBS. The last subjective reported case of leprosy in Antigua and Barbuda was actually 2006, sorry. Don't want to cause a public health scare, 2006. There are no cases in our database going as far back as 2015. And you see the Lepers Act is quite archaic, using several terms that are considered inappropriate. And with that, I say thank you. Any questions?
Thank you so much. I'm going to ask all presenters to wait until the end. In the interest of time, we're going to move swiftly on to our next presenter. So thank you for holding out and not running away. So right now, I'm going to invite Dr. Vanish Gulati to present on interdisciplinary variations in lower GI bleeding guidelines and AI-driven thematic analysis. Is he here? Okay, since we don't see him, I'm going to invite. That was a call for him, last call. All right.
Hello, can you hear me?
Yes, we're hearing you. Once we get the go ahead, we'll begin.
Okay,
Oh, we're good to go.
all right, sounds good. Okay, I'm sharing my screen. Let me know if you see it.
Yes, we're seeing your screen.
All right, perfect. I'll get started. So, hi everyone, my name is Vansh. I'm a recent graduate from AUA. I'm very excited to talk about some of the research I've been working on. First off, we have interdisciplinary variations in lower gastrointestinal bleeding guidelines. And the way this project really started was from a clinical observation. We saw that a patient would come into the ER, and all of a sudden, there's just lots of miscommunication between different specialties. You have gastrointestinal, GI, you have interventional radiology, general and colorectal surgery, all recommending different things to be done for the patient. And it's a really common problem. About 30% of all GI bleeds account for a lower GI bleed, which means anything below the ligament of Treitz. And management is usually multidisciplinary. Multidisciplinary care is usually great and usually leads to very good outcomes for patients. But we hypothesize that this is one of the areas where a multidisciplinary approach to care might actually be harmful for the patients. So that was how this idea was really born. We saw that there were different things being recommended by all four specialties, and we wanted to do a thematic analysis to officially analyze these four guidelines and see where the major points of discordance were. So for methods, did a deep we did a deep literature review, and we analyzed four key reference texts. We got the appropriateness criteria from the American College of Radiology. We got the clinical practice guidelines from American College of Gastroenterology. And believe it or not, there are actually no guidelines from the Medical College of Surgeons or the ASCRS, which is the colorectal surgeons. So we actually used their official textbooks and we found chapters from them. So we used those as substitutes. Then we used the analytical model of ChatGPT, which is GPT-o1, to identify common points along the management algorithm. So each of these guidelines had a management algorithm, and we used ChatGPT to identify points where there were common nodal points between all four of them. And these four nodal points and the management were identified based on two things. The first one was the next step in management, and the second was the strength of recommendation. And this was calculated using a percentage agreement with a tiered approach. There were 2 points being offered for complete agreement between the societies, only 1 point for partial or weak agreement, and 0 points for no agreement or disagreement. I think the next few slides will make this a bit more clear. So when we did the percentage analysis, we found out that most of the divergence, which we described as less than 60% agreement, was between recurrent bleeding after a TAE. So what this really means is that patient came in with a GI bleed and an embolization was attempted, but the patient continued to bleed. And there was greatest interspecialty divergence when it came to cases like this. The second one was recurrent bleeding after endoscopy. So patient came in, a colonoscopy was performed, but the patient continued to bleed. And we found that this also had a great interspecialty divergence. And finally, obscure bleeding treatment, which simply means that a bleed that's not being able to identify, you can't really identify the source of the bleeding. And when it comes to treatment of such bleeds, um, that's when we had a lot of disagreement as well. So those three were the major red flags for us: recurrent bleeding after endoscopy, after TAE, and obscure bleeding treatment. We also saw moderate disagreement when it comes to first diagnostic test for unstable patients. This table right here just adds another layer of reliability to our methodology. What we're seeing here is one specific case, for example, ongoing recurrent lower GI bleed after colonoscopy was attempted, but the patient continued to bleed. And what ChatGPT did here is it gave us the recommendation from each guideline. For example, ACS, which is American College of Surgeons, they recommend doing an embolization in this case. And how we were able to back this up was that we asked ChatGPT to give us a verbatim quote from the ACS textbook that kind of backs up what it's recommending. So you can see the code right here. For ASCRS, this was they recommended performing surgery with a segmental colectomy, and here's the code that explains this or backs it up. For ACG, they recommended repeating a colonoscopy, and for American College of Radiology, they recommended going with the TAE. As you can see, here we get 100% agreement between ACS and ACR, but there's disagreement between ASCRS and ACG. So that gives us a specialty agreement of 50%. And this is just one of the examples that I use here to kind of explain how we arrived at this table right here. So with that in mind, I would like to talk about the next steps in conclusion, that here we've identified a very significant clinical gap, that even though there's consensus on some key decisions, there is a significant divergence when it comes to management of recurrent bleeding after endoscopy, after embolization, and especially treatment of obscure bleeding. So our goal is to help identify these clinical gaps and make sure that we can improve multidisciplinary care when it comes to lower GI bleeding. And what I'm really excited about are the next steps for this project. Right now, this is what I'm working on, is a guideline author survey. What this means is that we have identified major authors who have been publishing a lot of guidelines for colorectal surgery for lower GI bleeding from each of the specialties. So we've made a big database which has authors from each of the specialties, and we're going to send them a survey that we've prepared. And we're working with one of the best or one of the most well-known colorectal surgeons, Dr. Stephen Wexner, who's helping us kind of disperse the survey. And once we get the survey, which kind of reaffirms our hypothesis that there is a divergence when it comes to lower GI bleeding guidelines, we're then going to move on to the Delphi consensus analysis. The Delphi study is it's a great way to showcase that there is divergence, and it helps to arrive towards a common agreeable point. And then finally, I know this is hopeful thinking, but the best outcome would be to get the studies or get the results from the Delphi analysis, and then hopefully um, hopefully form a shared guidelines task force by all four specialties, so that we can work towards one single unified guideline for this common and important clinical problem. So thank you so much for your time, and I'd be happy to take any questions or any suggestions about the study.
Thank you so much. And we finished with a little time to spare, which allows us to catch up. So Dr. Gulati, I'd like you to just stay online, okay? And in the interim, we're now going to invite once again our first poster presentation Poster presenters are reminded that we have 4 minutes each. So Dr. Samuel Obegbusi, please join us on stage. Please welcome him as he's going to discuss pregnancy termination following prenatal diagnosis of exencephaly and anencephaly in an alcoholic woman.
Thank you very much. American University of Antigua. Thank you very much, the management of the university, our professors here, consultants in our midst, doctors, and students. I mean, my fellow students, because we keep learning every day. I'm going to present on a burden issue in neonatal as well, both obstetrics and pediatrics area, which is anencephaly. It appears to be a real condition. However, it's something that we seldomly see in our community. And this is the case of a teenage girl who presented to our hospital, Mount St. John Medical Center, currently Celeste Bed Medical Center. This lady worried, full of anxiety, hoping for us to come, to tell her that the result is not what it is. Because her previous visit, she went to her private doctor who told her that she's having bed defect, which the head of the baby is involved, and which is not compatible to life. So she came to the hospital seeking for second opinion. And from her point of view, she had no antenatal care. Her first care was the news that she had. So she's seeking for opinion to see what next to do from there. All her variables appears to be okay. Physical examination appears to be okay. Her history along the line made us understand that she's having an issue with alcohol use. And from our investigation, or from the history we took from her, I realized that she's an alcoholic at such teenage age. And over the time, there was no medication given to her. She had no antenatal care, definitely. And she didn't take folic acid as a precaution to prevent neural tube defect, which is a standard we use. So the fetal rate, when we run this diagnosis, we realize that her WBC seems to be high. However, there's nothing pointing towards infection. She had no fever. She had no clinical presentation of infection of any kind. So on physical investigation, she had we asked her to go for ultrasound to rule out whatever she's thinking to make sure that we clear her. So on fetal ultrasound, heart rate was okay, bilateral parietal diameter was okay, head circumference was okay, abdominal circumference was okay. All the physical biography was okay, only the abdominal, the cranial section, which shows abnormal cranial region, showing a brain mass of about 2.15 to 2.63 cm, with heterogeneous tissue and an absence of cranial vault, as seen in this picture. This is the ultrasonography showing a mass that is pointing towards the anterior, which is the face, and the head posteriorly. You can see the herniation of the brain out. One thing about this condition is breaking the news, which is very, very important. And such news is devastating. So it required a collective medical effort, not just for physicians only, but as well the psychologists, especially I'm happy in a hospital we have a section for social counseling, and as well other team members that constitute the OBGY department. So after speaking to this lady, we told her that her condition is not compatible to life, considering the massive herniation of the brain. And despite how devastated she is, she comes to the conclusion that termination is the only solution after this, at least to limit the effect. Okay, so we commence termination of the pregnancy, and in this case we use misoprostol because we don't have mifepristone, misoprostol, based on the requirement by the FIGO. They require that you commence with mifepristone before using misoprostol. So in this case, we don't have the first line medication or the initial medication for the termination of pregnancy, so we use what we have available in our department, which is misoprostol. So we started misoprostol first day. This termination took us about 3 days. And at the third day, we were able to bring out the baby, which happened to be this. So you can see the massive herniation at the frontal lobe and the placenta. Everything was intact, only the defects in the brain, which is not compatible to life. So at 19th week gestation by the ultrasound, by LMP, the baby seems to be 20 weeks and 4 days. So in summary, anencephaly is a congenital defect that characterized by absence of major portion of the brain skull, while exencephaly is a precursor of anencephaly in the presence of relative normal appearance, appeared embryo of fetal brain that is not encased in the calvarium. So physiologically, this can happen anywhere of the body, this neural tube defect generally. If it happens within the cranial part, anencephaly or other neural tube defects can occur, including exencephaly and encephaly. If it happens towards the caudal aspect, spinal bifida and the rest can occur. So far in Caribbean, Barbados seems to have a low incidence or low case. Barbados have a low case compared to other countries with about 0.3 out of every 1,000 baby. And the risk factors include genetic factor, which professor that spoke earlier, Professor Collaborators, emphasized on. The risk factor, genetic, methyl hydrophosphate reductase is a very big important genetic that helps to metabolize the folate and convert it to folic acid and make it absorbable by the body. And here we are looking at retinoid acid antimetabolite, which is very important because this is where the research, modern research is going towards the effect of retinoic acid in neural tube defects, which I will encourage others to go into that. Not only folic acid now that we are looking at as well retinoic acid effect on neural tube defect. And preventive management, we are looking at encouraging women who are alcoholic into stepping up their dosage, at least trying to give them up to 400 micrograms of folic acid as a preventive measure, knowing that alcohol could possibly or potentially cause neural tube defect in these children. And this is our reference, and thank you all.
Thank you very much for an interesting presentation. And we are still now once again shy of time. So without further ado, I'm going to invite our next poster presentation, and I'm asking us to be cognizant of our time. And we're inviting Dr. Guillermo Alberto Quiepo Cagabero to present on reconstruction and triangular rotation flap following basal cell carcinoma excision, a report of 3 cases. Please welcome.
Good afternoon, everyone. My name is Guillermo Alberto Queipo Caballero. I am oral and maxillofacial surgeon. Today, I would like to share with all of you our paperwork, which title is Reconstruction with Triangular Rotation Flap Following Basal Cell Carcinoma Excision Report of 3 cases. Our objective today is to show the reconstruction with triangular rotation flap following basal cell carcinoma excision. To address this objective, we describe 3 cases treated at Sir Letterberg Medical Center with basal cell carcinoma histologically confirmed located in sensitive facial regions such as nose, lip, and periorbital region. The surgical approach showed the resection of the tumor with oncological safe margin, the triangular rotation flap technique performed, and how the patient were followed at 3, 5 days, 2 weeks, and 1 month. Keep in mind 3, 5 days. The ethical concerns were signed by all patients involved in the study. Now we are going to present the cases. So it is said that one picture is able to talk more than songs and words. So means that here, well, as we see, we show the process from the beginning to the end, how we can manage the patient. So in the first case, it's a 64 years old male presenting nodular shape, granular texture, and fair consistency located in nasal dorsum about 1.1 centimeter diameter. The outcome result that you see there, the healing process was uneventful. At 3 months following, the patient showed excellent contour preservation and minimal scar visibility. No recurrence was observed. This is the first case that you see. In the case number 2, a 76 years old male presented with a lesion with ulcerated shape, hard consistency located in the upper lip, right side, about 0.9 centimeters diameter. As you see there also, the result is the patient reported high satisfaction with the cosmetic result. In the last case, is a 55 years old male presenting an infiltrative basal cell carcinoma on the external contour of the orbit, 1 centimeter diameter approximately, and as you can see also the final result there. So the flap remaining stable with good color and match, no evidence of recurrence too, right? In discussion, we can say the triangular rotation flap is a versatile reconstructive option for a small to medium facial defect following basal cell carcinoma excision. Across the 3 cases, several advantages were consistent, such as excellent vascularity, reducing risk for necrosis, ability to redirect tension, and prevention distortion of nearby structure. Aesthetic scar placement often along natural facial lines. Short opinion time compared with more complex flap or graft. Compared with skin graft, triangular rotation flap provides superior texture and color match. They also avoid contour depression as common to see in drawback of the grafting. Limitation include the need for adequate adjacent skin laxity and carefully planification to avoid dog ear formation of excessive tension. We can conclude, say that triangular rotation flap represents an effective and aesthetically favorable reconstructive technique following basal cell carcinoma excision, particularly in facial region. The 3 cases presented demonstrated consistent success, minimal complication, and excellent cosmetic outcomes. This method should be considered a reliable option for the surgeon. Thank you.
Thank you very much. Once again, we're going to be reserving questions until the end. Thank you so much. We've had excellent presentations so far. please will Dr. Justin Mutiram come, and he's going to be presenting on stage limb salvage of an infected ankle non-union with bone loss using fibular autograft, hindfoot nailing, and local antibiotic bicomposite in a resource-limited setting. Dr. Justin Mutiram? Hello.
Hi, good afternoon all. Thanks for the opportunity to present. Thanks to AUA. Some members of my team are joining. This case is a 56-year-old chap who presented to Celesteburg Medical Center with a chronic infected open ankle fracture non-union. And it presented a lot of challenges. Being from a small institution with limited resources, we often face challenges in complex reconstruction. The key challenges here were to decide on amputation versus limb salvage, and we decided to do limb salvage. As you can see here, he presented with an open ankle fracture with gross contamination and a severe pilon type fracture that would make anyone in any level 1 trauma center in the world have a head scratch. We initially managed him with external fixation and primary closure, which eventually failed. We went on to attempt orthoplastic reconstruction with a reverse flow scleral flap to cover the bone. This eventually became infected, and he was left with a residual non-union and deformed ankle. At this stage, we decided to use a stage reconstruction for him, where we made a plan to go in, resect all the dead bone, put an antibiotic cement spacer inside you, utilizing the masculate technique, and put local antibiotics inside, which would help control infection. After 2 months, he went on to have no infection and a preserved soft tissue envelope. We then took him back into theater, removed the entire antibiotic cement spacer, and we harvested his fibula from his ipsilateral limb, and we used that as a cortical strut graft to put around an intramedullary device. At present, he has a healed limb, he has a stiff ankle joint with a fused ankle, he has no further infection, and he has a shoeable foot and can return to the workforce shortly. Cases like this showcase what we can do in resource-limited settings using established principles, orthoplastics approach, MDT approach, and using antibiotics, surgical debridement, controlling the soft tissue envelope, and eradicating infection. Thank you all.
Not only excellent in presentation, but excellent in time management. Thank you so much. Okay, our last presenter for the posters, before we move on to our next 2 sections, is going to be Dr. Siobhan Bell-Jarvis, who's going to present on gastric pneumonitis, a tale of 2 preterm infants with necrotizing enterocolitis. Please welcome her back.
Okay, thank you once again. So I'm presenting on gastric pneumatosis, the tale of 2 late preterm infants with NEC. Of note, gastric pneumatosis is actually very rare. We have fewer than 40 cases that have been described in the literature since the 1960s. Gastric pneumatosis is associated with fulminant necrotizing enterocolitis and gastric outlet obstruction, although you have had other associated findings to include steroid use in your preterm neonate, passage of the NG tube through the mucosa into your stomach wall. But this case report highlights that gastric pneumatosis does occur, and in fact, these are the first 2 cases of gastric pneumatosis ever seen here at the Celeste Bird Medical Center Neonatal Intensive Care Unit. It is clinically important because we must be able to recognize this pathognomonic sign. When we saw the first case, we didn't know what it was. We missed it, we had to research it, but when we saw the second case, we didn't miss it at all. And so it might be important to introduce this concept even within the medical school framework. So there are 2 cases. Case A is a male neonate. Mother was 25-year-old, multiparous, 35 plus 2 weeks. She had preterm, pre-labor, prolonged rupture of membranes. There was no history of antepartum steroid use, and she did not receive antibiotics. On day 1 of life, baby became distressed at 6 hours, was screened, first-line antibiotics were given, and first line for us is ampicillin and gentamicin. And of note, cow's milk formula was introduced within the first 24 hours of life. Coffee grounds was subsequently noted, and therefore baby was kept NPO for 48 hours. Feeds were resumed by day 3. However, by day 7, baby was quite irritable with abdominal distension, had to be kept NPO, was rescreened. Thrombocytopenia was noted, and the baby was placed on triple antibiotics. This time we went second line, so we went augmentin, ceftazidime, and we added metronidazole. Baby was kept NPO for 10 days, received triple therapy for 10 days, and was discharged home by day 25. And then we look at case B, and we can think of similarities now as we go through. Female neonate, twin gestation, dichorionic diamniotic, gestational age of 34 plus 2. Mommy was 23-year-old, multiparous, again, preterm, pre-labor, prolonged rupture of membranes. However, this mom received antepartum steroids and antibiotics were received. Because as per our institutional policy, once you're less than 35 weeks, you are automatically screened. So baby was screened, first-line antibiotics, and of note, cow's milk formula was started as there was no breast milk available. By day 3 of life, we have poor feeding, temperature instability, marked abdominal distension, and day 3 to 18, baby had thrombocytopenia, anemia, required packed red blood cell transfusion, and actually was stepped up to second-line antibiotics and treated for 14 days. Baby was kept NPO until day 18 of life and subsequently discharged home. So what are the common factors here? Prematurity, low birth weight, preterm, pre-labor, prolonged rupture of membranes, and the use of a cow's milk-based formula within the first 24 hours of life. So I wish I had a pointer here. Okay, but if you notice, may not be able to pick it up, but we can see the first arrow. Gastric pneumatosis basically looks like a nice rim around your gastric bubble. So in the first image, you notice that you have that nice rim highlighted there. That is for case A. And if you compare that to case B, you see a similar rim, but what I would like to identify as well is what we call pneumatosis intestinalis. Very classic for NEC, where you see air actually trapping within the intestinal wall, and it looks like a tram track sign. And then here, in terms of your cross table lateral, you notice that you have that sort of radiolucent line around the gastric bubble. Now, very important here is to differentiate that from pneumoperitoneum. If you had pneumoperitoneum, we would expect to see air tracking above all the gastrointestinal contents. And so the NEC criteria used were the modified Bell's classification for both cases. So gastric pneumatosis, is exceptionally rare. However, it is real. We noticed that in the 2 cases, within a short period in our NICU, we had gastric pneumatosis for both babies. We noticed that in a French NICU, they had a similar cluster, and what caused this was actually milk or lactobacillus. And so the question for us is the utilization of cow's milk formula a predisposing factor to developing gastric pneumatosis? Interestingly, for case B, twins, both babies would have received formula. One developed NEC, one did not. So are there markers that we can look at? Many studies have also looked at fecal calcitonin as a potential marker. So in conclusion, we know that you can have sporadic cases of gastric pneumatosis in a NICU. We have to, however, review the radiological findings, ensuring that the staff are familiar, so once you see it, you never miss it. And then we have to also overview, or rather review, the protocol governing the feeding strategies in our NICU. Is there a need for a breast milk bank? Should we gradually introduce formula in smaller volumes and graduate slowly? And so I hope this has been useful to you. These are references. We thank the patients for giving consent for displaying their data today. And you have the QR code if you want to look more at this publication. Thank you.
Thank you once again, Dr. Bell Jarvis. Right now, we're going to move swiftly on to Dr. Vansh Gulati once again, who's going to present on discordance between ERAS and geriatric perioperative frameworks in colorectal surgery and AI-assisted thematic analysis. He will be presenting online.
Hi, can you hear me? Hello?
Can you share your screen? We're hearing you, and you
Yes.
can share your
Do you
screen.
see it?
Yes, we can.
Do you see my screen? Okay, perfect. So I'm going to be presenting discordance between enhanced recovery guidelines and colorectal surgery guidelines, especially when it comes to frail and older individuals. So enhanced recovery after surgery guidelines, a set of guidelines are very popular. They've been in practice for more than 10 years now, and they do lead to very good evidence-based patient care. And the main goal of enhanced recovery guidelines is to decrease hospital stay and make sure that patients return home as soon as possible after surgery. We noticed that while emphasizing accelerated recovery after surgery, it does um, it does lead to some harmful effects, especially when it comes to the older population. And that was our hypothesis that while ERAS promotes accelerated recovery, they are um, they are actually putting older and frail patients at risk. So that's what really led to the birth of this idea. So for our objectives, we decided that we wanted to do a thematic analysis, a qualitative research between these two guidelines so that we can find out if there is divergence between enhanced recovery and established colorectal guidelines for frail individuals. A side objective was to hope that in the future, these enhanced recovery guidelines could be updated and modified so that older and frail patients get some more consideration and are better taken care of, even while following these enhanced recovery guidelines. So for our methods, we first started off with a deep literature review. We identified 5 important guidelines by the American College of Surgeons, the American Society of Colorectal Surgeons, and the American Society of Anesthesiologists. And this is really interesting because the previous methodology we were using, we got some fair feedback and criticism on that methodology. So we kind of innovated with this one. We did a literature review again. We found out that really the fathers of qualitative research, Brown and Clark, and we used their methodology and kind of used some help of AI with that. So what we did here was that we took verbatim recommendations from all 5 guidelines and put them together into a big Excel sheet. We then used we then had a column for what guideline it belonged to. For example, this one belongs to the 2023 Enhanced Recovery CPG guideline. And then we followed by a type of the guideline. So this could be either ERAS or geriatric. Those were the 2 types we used, and also just put a code for them for easy reference. We also specified a domain, which means it could either be a preoperative guideline, a post-operative guideline, or an intraoperative guideline. And finally, we assigned a code to all of them. What code really means here is that we are analyzing this verbatim recommendation and summarizing and synthesizing that into a smaller code. This is where we use AI, but everything was human verified. So it's more of an AI assisted study. And something we did after this step was to kind of group the codes together based on similarities. For example, all the guidelines that were about delirium were grouped together. All the guidelines that were about um, anesthesiology were grouped together. Everything that was about cognitive risk was grouped together. And then we analyzed these groups themselves to see the overall theme in these groups, if there was convergence or agreement between ERAS and colorectal surgery. if there was divergence. And that's what we found here in the results. That divergence was most evident in 4 domains. First one being frailty and cognitive risk assessment. The colorectal surgery guidelines on for frail individuals do emphasize on this, but this was missing from ERAS. The second one was delirium mitigation and medication safety. This was again emphasized in the frail guidelines, but ERAS focused more on acceleration-driven multimodal strategies. The third one was individualized discharge planning, which was more so evident in frail guidelines, whereas ERAS focused more on standardized early discharge pathways. And finally, aging-informed anesthetics was more emphasized in the frailty guidelines, whereas more standardized physiologic goal-directed therapy was emphasized in the ERAS guidelines. So in our conclusion that there is significant divergence between ERAS and geriatric frameworks, and it would be amazing if ERAS guidelines can be updated to give more consideration to frail individuals while also accelerating their care. So thank you so much.
Excellent. Thank you so much. Please give all of the presenters thus far a round of applause. I'm now inviting any questions for any of the presenters. If there are any questions for Dr. Sherry Tulloch, Dr. Siobhan Bell-Jarvis, Dr. Gulati, Dr. Ugobosi, and Dr. Guillermo, and Dr. Mutarim. I'm so sorry I'm doing this to your names. I really apologize. And if there are any questions, please come forward. Please give one last round of applause to what was an excellent set of presentations. Very informative and very interesting. So I now hand you over to the organizer, Dr. Juan Acuña.
Thank you very much. Okay, so the moment that at least the students have been waiting for. That's why they're still there, right? Good. First, I would like to thank a lot of people. First, I would not be able to do this without a supportive and proactive leadership. So to Dr. Bell, Dr. Graham, Dr. Hood, thank you very much for supporting not only the creation of the AUA PSPH Research Center, that now serves as the support system and the hub for research, especially for our students and faculty. Second, the amazing faculty that has been supporting the students throughout. So without you, I would have no collaborators, friends, moderators, partners in crime. So thank you very much, and I would like a round of applause for them, because actually to yourselves. And definitely none of these would have any sense whatsoever, and it would not be possible without having the amazing group of critical mass of our students who have shined today. I think that we have achieved a level that is unparalleled. And I think our external speaker, invited speakers, were telling me how impressed they are about the type and the quality and the level of research that our students are achieving. So, an applause for our students. Thank you very much. And of course, to everybody else that makes this research day possible, but my two right hands, Dr. Linares and Nita, they were amazing throughout all the time that we spent organizing this research day and tomorrow regional symposium and the workshops. So just a few more minutes. I have to say that because of the quality of the presentations, our impartial, unbiased set of external raters had a lot of trouble selecting the top research projects. So they selected two by 10th of a point. And because of that, I feel empowered, so I am going to make an executive decision. Again, I know that my leadership will support these. I cannot give 2 prizes. I have to give 3, right? So one of the criteria for getting an award here is to present at a scientific meeting. I think that we have a wonderful scientific meeting, and you guys just presented here. So we have a 3rd award. So the 3rd place that will get an AUA Research Award is sorry, I just want to make sure that I read okay, is diagnostic accuracy of fetal cardiac magnetic resonance imaging in cardiac and thoracic vascular anomalies. Great. So I don't have awards to give, but you will be receiving an award, okay? Great. On the 2nd place, the effectiveness of Nordic hamstring exercise in preventing hamstring injuries in soccer players. A systematic review and meta-analysis. Congratulations, well done. And the first Dr. Mohit Bandari's award in research is platelet-rich plasma formulations for acute hamstring injuries and meta-analysis. So, thank you very much to all that listened, supported, helped, etc. Our research, our researchers, and our research day. And now, we're going to close the day with a fantastic presentation by Christian Clowers, who had been walking the way back there. And Christian is a photographer, and he is from Belgium, and he has been doing explorations and have been going to the most amazing places, as you will be able to see, all of them fragile ecosystems that are affected or will be affected by climate change. So I will let him present his story in a much better way. Christian. And we might need help connecting Christian's computer. So you already tried it? Yes. Okay, great. So you know what to do. It's in, okay. Hello?
Thank you.
What?
Test 1, 2. Say it again. Yeah, well, we cannot hear him. Mike.
Use the handheld mic.
Okay, the handheld mic.
Okay.
So I won't use this.
This one? Any of these?
Okay, thank you. Hello, test. All right. Welcome, and thank you for being here, everyone. So, my name is Christian Klauwers. For the last 15 years, I've been documenting what you can call the front lines of climate change. The front lines of a changing world, environmentally, but also culturally. It's a story of nature, it's a story of us, as one out of 8.6 million species. Now, I believe in the power of image. If you look at this, I think this is very powerful to visualize climate change. It's a spectrum. Every bar counts for 1 year. Last century, our planet has been warming up faster and faster. Now, I'm a documentary photographer, which means that every single photo you will see anywhere, today, publications and so on, is exactly what I saw, is exactly what my eye has captured anywhere on this planet, including this one. Climate change is a human story. And the ones that are less contributing or least contributing are unfortunately most affected, such as people living in small independent development states, such as indigenous people worldwide. This is a photo of Inuit, Arctic indigenous people. I took this photo about 12 years ago in a stormy weather. You can call it a whiteout. You see this small patch? That is my only reference point. Now, these people, they know how to navigate. They will not get lost. They have ancient knowledge. They have ancient wisdom. They are in balance with nature and understand when they take something away, then they take something away of an entire system they're part of. I have only one infographic in between all the photos that I will show you. I think it's a very powerful one to tell you exactly what I'm saying. In, let's call it modern society, we are for sure the top predator. We extract, we use, I can use the word use, ecosystems as resources and dominate. What you see on the right is how farmers, fishermen, indigenous people still live, inseparable from nature. This is the high Arctic, as I took this photo in 2013 in winter. This is how it should look like. The Arctic is warming up fastest, 4 to even 6 times faster than anywhere else in the world. This is a photo I took in 2013 in a valley in Svalbard, an archipelago about 1,200 kilometers south from the geographical North Pole. I've been going back and back every year, and I took this photo about 2 years ago and 3 months later. We're only 1,200 kilometers from the North Pole. There's no ice, no snow. Atmosphere, air is warming up. So is soil. So is our ocean. This has vast consequences. We have to look to the Arctic to understand what is happening. Polar regions are barometers of our climate. They're meant to keep our Earth cool. Now, I sometimes also use the help of the European Space Agency for satellite imagery, and I've been digging a bit in their archives. From space, you also see it. So that's a runway, and the photo was taken exactly here. It was this valley. So this is the coldest day in the last 25 years. That was the warmest. Now, major consequences. Arctic landscape, what do you see? Well, in the middle of the photo you have the horizon with a little house. Nobody lives there. This is a cabin used by scientists for remote research, charging batteries, sheltering for polar bear, and so on. And then the first thing that you notice, everything on top of that horizon is one and the same mountain. And then you see these S-shaped patterns, these eroded S-shapes. This used to be a glacier, which has eroded in those mountains. Glacier disappeared. This photo is a witness of what once was and is not there anymore. Same for the foreground. Thaw. Soil warms up, becomes less stable, swampy. The permafrost permanently frozen soil is not that frozen anymore. And the active layer, the top layer, is freezing, is warming up fastly. And then some strange objects appear, like plastic in a tube, or a piece of wood, a tube here. All of these artifacts pop up. Now, all over the Arctic, north of that Arctic Circle, 66 degrees northern latitude, you see it more and more visibly, how soil is really changing. And it has consequences for flora, coastal erosion, also infrastructure. People live there, both indigenous people, also scientists. Soil is cracking open, permafrost is thawing, and deeply hidden in that soil, there is methane, vast amounts of methane. Methane is a greenhouse gas contributing to global warming, which is 84 times more effective in keeping heat trapped in that atmosphere for the first 20 years compared to CO2 levels. On all these COPs, the climate change conferences, my personal belief is that we really should put more stretch and importance on methane. So these are a selection of photos I took in Svalbard, in Greenland, and in Arctic Canada as well. You still see the permanently frozen layer. And that top layer, which is called the active layer, is always getting thicker and thicker, faster and faster. Sometimes you see what is called thermokarst depressions and sinkholes like these. So the environment is changing. I will put a different case study here. I did a project about 7 years ago in Lofoten. Lofoten is continental Europe, much more south. And in Lofoten, it's already the Arctic, not the high Arctic. People live from fishery, okay. But they have specific variables, let's say. For an ancient tradition, more than 2,000 years, they're putting these fish on racks just outside. In my country, I'm from Belgium, it would rot. Birds would come, it would rain, then the sun and so on. In Lofoten, the airflows, the temperature, humidity, the winds were always stable. So they could do this for thousands of years. There's a theory that Vikings knew this already, and that's why they went to Greenland and to, what is it, Newfoundland, right, in Canada? Now, this is not just a person inspecting fish. This is one of the 5 people living there that is an expert. He can smell when this fish is ready. This expert told me things are changing. Our fish is starting to rot. Now, this fish is also a protected label, like champagne and feta. In Europe, you have these brands that you cannot just copy the name. Feta is specifically, according to rules and so on, made in Greece. This fish is the same. These people are losing not only their means of survival, but also much more than that. Also, this region has very little land to live on. Like so many coastal regions in the world, these people are living by the water, and in this case on stilt houses. And they see consequences of rising sea levels. Another case, this is in Canada. This is an Inuk. His name is Noah. In 2024, I visited Noah again, trying to really write down and document as much as I can of the ancient knowledge that is getting lost. Noah, he told me that he saw a ladybug. He's living 1,300–400 kilometers maybe from the North Pole. He saw a ladybug. There are no ladybugs there. So big consequence is vegetational shift, fauna that is shifting, and I will give some examples, and eventually also humans. Humans are also relocated or will be in the future. And this is what is at stake. The youth, and also this generational knowledge and culture that is getting lost. Another case, this is an aerial photo taken by the Norwegian Polar Institute in 1936 of what is a healthy glacier. This is how a glacier should look like, touching the ocean, the Arctic Ocean. It's a moving system. Now it looks like this. It's the fastest retreating glacier in the whole archipelago of Svalbard. I've been with a team of scientists from Taiwan and Lithuania. This is my latest project in the Arctic. I will return in July, different kind of project. What do you see? Well, that glacier, that retreat is huge. It's almost a mile, 1.6 kilometers. There is a spit and there is a lagoon. There's a complete new ecosystem, complete new reality, complete new environment, and complete new biosphere. So we are interested in two things. The evolution, of course, but also life and microplastics. So these are sediment cores that we took, analyzing historical climate records. And on that lagoon, we were also using manta nets to, let's say, scrape off the top layer, because plastics are now everywhere. Microplastics becomes nanoplastics, ending up in the air, raining down, ending up in stomachs of polar bear, and eventually also in our stomachs due to the fish that we eat. It's not a happy story. And in this remote location, so far so pristine, we did find a lot already, because they're still writing the outcome of it. Another species we were looking for, well, species, microplastics obviously is not a species. Another thing we were looking for is what is called Mrs. oculata. It is a key species for the Arctic food web. It's an indicator for environmental change. Eventually this will become fish. Really interesting. A glacier disappears, a lagoon is formed. What do we find? Tons of microplastic and also these species. And even in this harsh environment, there is always a biosphere, but it's changing and it's really vulnerable. The Taiwanese team, they were doing the research for microplastics on land with a simple methodology, taking a transection, just visually looking and finding microplastics. Now, this affects immune systems, destabilize ecosystems, and so on. This is my last infographic for today. Two really big concerns. Contamination levels, gradual buildup of these chemical substances. You can't get it out, and we are also top predators. And biomagnification. Top predators, they consume higher concentrations, and so it will add up from krill to fish to seals to polar bear, for the case of the Arctic ecosystem and food chain. I did my own experiment as well. I was there as a science photographer, also carrying a rifle. By law, you have to protect yourself to polar bears. And I walked 100 meters on a beach, random, 100 meter, one straight line. This is what I found. Now, climate change is inherently related to biodiversity. There is a triple planetary crisis going on: climate change, biodiversity, and pollution. Biodiversity includes our own food as well. I normally don't put a lot of text, but this is one to remember. 1 million out of 8.6 million species, both plant and fauna, animal species, including ourselves, are being at risk of extinction to a certain degree because of humans. Now, in 1984, the Nordic countries, they asked themselves, well, we have these endemic seeds, like every country in the world, and we don't really know how long we can preserve. We live in the Arctic, it's cold, it's dry. We should test. We should really conduct an experiment, and so they did. And they looked again for Svalbard. That's why I'm always returning there. In Svalbard, you have a history of mining. And in an abandoned, decommissioned coal mine, which is now property of the Norwegian government, they said in 1984, we're going to put a wooden door with a copper engraving saying Frøyhall, the Hall of Frøy. In Nordic mythology, it is the god of agriculture. And there is a date, November 10, 1984. Behind this door, they started an experiment, the 100-year experiment, which is still going on. It is a seed storage facility now. They have put a black container with 20 wooden boxes, exactly the same, containing exactly the same food crops. Samples of these endemic seeds growing in these 5 Nordic countries. Every 5 years, they would open one of these boxes. I entered. These are inaccessible vaults with the help of the Food and Agriculture Organization of the United Nations, which is checking. It's an advisory board. Every year, they inspect once. That's how I took these photos. It is called the 100-year trial, and it's still going on, obviously, 42 years later. This box will be opened in 2066 on the 1st of December. So more boxes. Already, they have drawn a lot of interesting conclusions, including on pathogens that were brought in these boxes on these species, on these crop seeds, because it's as important as the crop itself, right? Fungi and so on. Now, out of this came an idea that is much more ambitious. The Global Seed Vault. It's not only the least accessible room in the world, it's perhaps also the most important, therefore least accessible. It is really the genetic library of the planet, because this is the ambition for every single nation, every country on this planet. It was built in 2006, and it really came out of the first idea in that coal mine. It's about 200 meters further. They were digging 130 meters above sea level to cope already with sea level rise, inside this really seismological stable environment that is protected by treaty, which is a demilitarized zone by treaty, I should say. The Svalbard Treaty, or Spitsbergen Verdrag Treaty. And then 130 meters deep in this mountain, where this is the entrance, you can see this, but not behind this door, you have a tunnel, 130 meters deep in that mountain. You have a control room at the end. When I was there in 2014, they had a Windows 98 or something. I was laughing with that. I'm like, oh, and they said, yeah, it works, you know. So what happens? Once a year, the door opens, and seed crops worldwide are being brought together, and our input will be input in the system, and will then be stored in one of these 3 rooms. Capacity is 4.5 million varieties of seed crops. We have no idea how many seed crops there are, but it's quite complete. Actually, the real ambition is to be a safety backup of every genetic bank in the world. There are about 1,300 genetic banks, gene banks. So this is already a rare photo, happens once a year. And this is a photo of something that is not there anymore. It's a tunnel, but in 2016, it was opened in 2008, built in 2006, opened in 2008. 8 years later, there was already water infiltrating. The permafrost is thawing, this mountain is warming up. Already there was water. Luckily, no seeds were harmed. That is not my photo. I will tell you when it's not. This is mine. So already they had to enforce the tunnel to this safety room, which is really cold, minus 18 degrees. There is a plant treaty established by the FAO, United Nations, worldwide, giving indication for how to preserve crops, minus 18 degrees Celsius. Behold the genetic library of our food, of 11,000 years of agricultural evolution. Every single country, the complete biodiversity of Canada, International Rice Resource Institute based in Manila with 126,000 species of only rice, and also 2 really special ones, and they're very symbolic. The People's Republic of Korea. This is beyond geopolitical tension amongst anyone. This is for humanity. And that one, they took it out after I took that photo. It's a Syrian box. During the civil war, the entire gene bank in Damascus, which was containing one of the most important species because it's a cradle of our civilization, one of them, where agricultural evolution really started, when people from nomads became sedentary, started first cities and so on. It already has proven its importance. Let's go out. The symbol of the Arctic, we're still north, polar bear. It's a marine mammal, can swim. Few people know that. It's a marine mammal, but it needs sea ice. It needs sea ice to hunt, to mate, to travel. Sea ice is in decline. And I have a little movie, an evolution of sea ice in the Arctic for the last 35 years. And you will see that it looks stable. It's like a pumping heart. And then after the years 2000, and especially after 2010, it's really shrinking. Have a look at the legend as well, sea ice age. It's becoming thinner and less old because of warming waters. I will tell you already that all ocean is connected. There's one ocean. I learned there are 5 oceans. There is only one. Now it's going really fast, you see? Sea ice is in decline. Now, the major consequences are so many for animals, for indigenous people who need that sea ice to hunt. But there is also what is called the albedo effect. Have you heard of that? The albedo effect measures how much sunlight a surface reflects back into space versus how much it absorbs. It has a function. All the ice, whether it's sea ice or glacial ice, needs to reflect the energy of the sun back to space. Light is okay, it's about heat, warmth. When sea ice is in decline, and glaciers as well, but now I'm talking about sea ice, this photo really symbolizes it. It's not white. What do you see on this photo? Well, you see a seal sunbathing. That's what seals do. A polar bear will have less chances now to catch this seal. It's his main menu. That's what he wants to eat. He wants sea ice where he stands on, makes a hole, and the seal will eventually come out of that hole, and then he can capture it. I have footage of that. I saw it with my own eyes. You see the reflection is actually a glacier tongue retreating. Glaciers are getting smaller. No ice, sea ice, glacier ice, means dark water. The water is dark. It absorbs that heat. And that is a phenomenon worldwide, especially in the Arctic, especially in the Southern Ocean, Antarctic. The only one that encircles an entire continent is the Southern Ocean. It's warming up really fast with all consequences. In Arctic Bay, and I drew this beautiful map here, this is Arctic Bay. That's the Northwest Passage. We're in northern Canada. You have a mythical creature called narwhal. This was perhaps one of the most difficult pictures I've ever taken. Narwhal are Arctic toothfish. They have a huge tusk. Now, it is one of the few whales, like belugas, that evolved into a species without a dorsal fin. It used to have a dorsal fin. We know that from fossils. But it helped him through evolution, moving under sea ice. That's his one protection system against the main predator, which is orca, or killer whale. Orcas cannot go, they are so smart, hunting group, but they cannot do like a white shark like this. So they will not be able to capture this beautiful creature if a sea ice flow is large enough. Unfortunately, without sea ice, and we already see that, I have only implemented one photo, but I can tell you an entire story about it. The short version is they're also migrating. Also, polar bear are migrating. So many species. I give you examples, symbols of the Arctic. But worldwide, so many species are migrating already, going to higher elevations, going north or going south. Polar bear, without ice, they go south. They're trying to find villages in Arctic Russia. Fortunately, we don't have a lot of news on that, but it's happening. They're looking for food. They're hungry. So orca are now moving more north without sea ice. This creature has 2 options, and he can't really choose. He either has to adapt or he will get extinct, like so many species. From north to south pole, I like symbolic photos. Now we're on Antarctica, the other side. Antarctica is famous for penguins, whereas this one would be the largest, the emperor penguin. This is the power of photography. For me, this photo was not only, it's very emotional, of course, it's sentimental. I looked him in the eye. He was standing there in the middle of nowhere in the Ross Sea, very inaccessible. He was completely alone. This creature is normally not alone. And it's a bit sad, and yet it's the most pure and most beautiful place on Earth. Very double. Now, most penguins are living, that's something that few people know, not really entire life cycles on the Antarctic continent. They use the islands around it. They are doing great in general, speaking in general terms. This one is not. This emperor penguin as well as Adélie penguin, they need ice. They need ice because their life cycles depend on the seasonal cycle of this ice flow, the sea ice, for breeding, foraging, and so on. Also Adélies. Another implication, look at this. This is sea ice. It means it's salty water, depending on the salt percentage, minus 6 degrees Celsius. Normally, fresh water is 0 degrees Celsius, will become ice, right? In Antarctica, it's salty, so it's different. Eventually, water will cool down and forms ice, right? Now, a big consequence, and you can see it very well on this photo, you see that the brown patches and layers underneath that ice. Do you see that also here in the corner? And there, these are algae, phytoplankton, the basis of the food pyramid. If you take away, if you diminish the ground layer of your food pyramid, the whole pyramid is shrinking. That is exactly what is happening. Another consequence, I will give you a bit more detail. Both emperors and adelis, they form colonies on sea ice to breed. You might have seen that, David Attenborough and so on. Sometimes sea ice comes too late or warms up and melts too early in season. What happens when these chicks are out of the egg, hatching, I think that's called, right? Then they need a certain amount of time for their feathers to form, to have a fat layer to resist that water. These are bird species, but they're like, they dance ballet, you know? It's beautiful to see them underwater. They're so clumsy on land, but in the water, you can barely catch them. Orcas have really difficulties, and leopard seals and so on. So sometimes entire colonies drown because the chicks are not ready yet. So I will also focus a little bit on the science that I documented. So we see that colonies are getting extinct. We see that there is also migration pattern. So yes, what do you do as a scientist? I'm not a scientist, but I document their work. I am a political scientist by education. That's completely different. Well, we have to understand what is happening. So we have to take samples, morphology, blood samples and so on, and geotag them to understand where these creatures are going. They live together, so if you tag one of them, it will be a significant representation. Unfortunately, this was 2024. We made world news because we did found the bird flu. Bird flu in, you will not believe it, the least explored place on the planet, and I have a map. The H5N1, it was found here. I don't know to which extent you know the Antarctic continent, but this is the least explored part, and it's only the one area or piece of land that was never claimed by anyone. It's called Mary Bird Land because of the Americans. Mary Bird was an American expedition, I think, and this is the Amundsen Sea. So we were really surprised to find bird flu there. Another type of research, acoustic research, hydrophones, drilling a hole through that sea ice, so you're back in the ocean, right? Just listening to whales, because also whales are migrating. Now, to understand climate and atmospheric history, you have to drill in the ice. I'm from Belgium, myself. This was used 132 years, roughly, by that Belgica expedition. It's okay, you probably don't know that, but we were really early in trying to do scientific work as a country. That's one of the very few achievements of the small country called Belgium. But anyway, they knew already. That's why I put this photo. Now, well, a lot of institutions are drilling. I've added this photo to show you on a very small scale. Drilling ice cores happens only in freshwater ice, the ice sheet itself, glacier ice, which was once precipitation, right? So these are the major drilling ice coring points right now, whereas this one is the deepest, but it's all relative. They went back in time 420,000 years. We can now look back in time 1.2 million years. It's the only way to understand what is, and we all know that, it's cyclic. We have ice ages and so on, interglacial eras. But there is much more than that, because never ever it was so rapidly, and especially the biosphere, the biodiversity is so rapidly in decline that scientists are talking about the 6th mass extinction. This is a Niels Bohr Institute where they keep all that ice. Now, freshwater ice, the ice sheet is freshwater, that's the natural water supply as well. When this melts, and it eventually does, these are 2 photos of an iceberg. You can say, this is like, it's named the Penguin Party, and this is a different kind of photo telling exactly what is going on, right? So eventually it will crack, it will warm up, and it will break and contribute to sea level rise. I've implemented a couple of photos, also this one, this one. It happens especially in what is called the Weddell Sea and the Ross Sea, so there is this massive amount of ice. It also counts for Greenland. These are the two tipping points as well. And that ice flows in the sea. 147 gigatons per year. To give you an idea, that's just a number for me, so I like to visualize. This is 1 gigaton. This is Manhattan. Some of you might have an idea about the size of Manhattan. This is 1 gigaton, and this is only Antarctica. So 147 of these will melt every year. And now I will focus more on who is really seeing that. Where I live, I have, well, everywhere in the world, you have, with all respect, more ignorant people saying 1 centimeter, so what? I have been going back to this region for more than 12 years now. Everything that is yellow is what I have now documented. And especially Marshall Islands, Kiribati, Tuvalu. They name this Kiribati, but they pronounce it as Kiribati. These are atoll states. They don't have land, basically, as you see here. Imploded volcanoes by origin, but they really have all the major consequences. And the first one is rising sea levels. They also have no material to build adaptation. So what do? Well, they try to build seawalls. They dynamite in the bedrock to have construction material. And then they build seawalls. You see them here on both sides of that road. This is a space photo again from the European Space Agency. That's how it looks from space. Do you see the airport? Gives you an idea. That's where you land. This is Majuro, capital of Marshall Islands. Now, this is a very symbolic photo because it's showing also how survival really looks like in the Pacific. It is a very densely populated island called Ibai in the Kwajalein Atoll. Dynamite to build seawalls. And I'm not talking about health implications. That's why you are also here, but I'm visualizing what is happening and what is at stake. The future of this boy, for example. That ocean that was once the bridge to the neighbor, and now in 2-3 generations, they feel fear. And I know I've been there months with these people, talking, interviews, asking questions, and trying to capture and showing the world what I saw. I've been to this island as well. I was lucky that I had this aerial because I was flying out. It's called LIB, L-I-B, quite difficult to reach. It is an exception on the reality because it has a freshwater lake. First concern, water. Second concern, food security. Third concern, well, there are so many concerns, right? I can keep on going. An example, I will keep this very brief. This is an island state called Nauru. Nauru is a modern story of ecocide. The origin is not volcanic. It was guano, which became phosphate, right? Phosphor, what is the name in English? So it's a fertilizer. Before we had pesticides and so on, it was worth gold. So they kept on digging and digging and digging, and their entire ecosystem is gone, basically. That's a very short version for Nauru. Another example of seawalls. Sometimes I can really also show what another problem might be, and is actually the reality, which is a financial constraint. So they were building and building, and suddenly, oh, no money anymore. This is the wall, and there it stops, and that's the open ocean. This is exactly the house where I've been staying 1 month in Kiribati, and I've been returning, but that was years later. In this case, they were looking in the sea for anything they could find, like bleached coral reefs to build a seawall. This is the country of Tuvalu. It's a sovereign state. It has a voice in the United Nations, just like Antigua. Tuvalu is the narrowest country in the world. First thing that pops up, coastal erosion. Water gives proteins to perhaps 70% of the world's population. All of these cities are at water. We take and take and take fish, okay? But water also takes away. In the case of Tuvalu, well, so many island states, but this is a very good example. With the help of the United Nations, they're planting millions of mangroves. Blue carbon economy and so on. They're capturing carbon, we need that, but they're also keeping the soil together. They're a barrier for these waves. These island states, they have sometimes as the highest point, not even 2 meters. I am 1.84 meters, imagine, highest point. Every centimeter counts for these people. And this girl, I will never forget this girl. So you have tides as well. Some of these people, they have family member on a different island. I was wading through the water. When it became higher and higher tide, I was looking back and forward and thinking, this is scary. I could drown. I don't know this sea. It's getting higher. I was wading through the water here, going to another island. Not everyone has a boat, right? This girl used a tire of a car, trying to be a voice for these people. When all of your soil is getting salty, they have to import, which brings us to the other question, waste, plastic, single-use plastic. What to do with waste? Waste management. This is the landfill of Tuvalu. I'll give you a couple of examples. I will get a little bit faster here. So this is Philippines. These are traditional fishing people, Olango Islands, with their boats. As you can see, for these kind of projects, I use aerials. It's a bird's eye, because it shows you what is going on. Huh? Coastal erosion, this was last year, federal states of Micronesia. Oh my God, I switched it off. That's another button here. Okay, federal states of Micronesia, the face of coastal erosion. This is maybe not harming anyone. That's me sheltering there, but it's there, it's everywhere. And this is what is at stake, again. Also humans. Palau, a different kind of island again, they came up with the idea of protecting their waters. Ecotourism, abolishing sun cream because it had this component years ago that was harming coral reefs, breaking it down, the calcium and so on. So it flourishes. And they came up with what is called the Palau Pledge. In order to enter this country, you have to sign it. You have to sign it. The only footprints that you will leave are those that will wash away. Very simple and very effective way of awareness, building awareness. Now, last year, some of you might know that, I was also invited at this beautiful university. These are photos I took on this island last year. The sargassum problem. This one, I really have to do research. That pink lake, I think it's related to drought. This is really very dry, and it's for sure some kind of bacteria that was flourishing there. But as some of you might have noticed, these are also, in this region of the world, there was always a Sargasso Sea, well, always, for the last 500 years. But now they're talking about, what is it called, the North Atlantic Sargassum Belt or something? It's so much more. We know that there is a part of it, it's the warming up of that ocean. These algae are flourishing, these sea algae. Sargassum is flourishing, but also fertilizer. The rainforests in Brazil, fertilizers from agriculture and especially also cattle, flowing into the Amazon, flowing into the ocean. We see that from even satellites. It's so useful, satellite imagery. So photos on this island and even on Barbuda. This is Barbuda. When I flew in last year, I saw it from the air, and I've never seen it in those quantities. So I was like, is that an oil spill? It was really looking weird. Another major challenge for so many regions, including this one, is intensifying of storms, including hurricanes. Irma, when was this? 2019? 17, thank you. Okay, I will start to conclude. I think we really also need to look more and more to the ocean. 1 out of 2 breaths, you will not believe this, huh? 1 out of 2 breaths are provided by the ocean. Oxygen, phytoplankton. Phytoplankton with photosynthesis, taking carbon, releasing oxygen, absorbing heat, regulating weather, local, and on the long run, climate. Some photos I took during all those months in my life that I spent on ships, quite a lot. I'm actually focused on marine science. I will be 3 more months on a scientific research vessel, the Belgian one and 1 Italian one, and I've been 1 month in January on the German one as well. So this is flying fish, a beautiful creature, not only that, but a beautiful example of how species adapt. Adaptation. The question is, and this is key, do they have the time to adapt? Because that change is so rapidly now. It's going so fast, and that includes human beings with all our technology. When I took this photo, I didn't even know it existed. It's a flying squid. Now, a very fun example, I thought it was the last non-photo slide, but I have implemented also this one, because I think nobody knows about this. In 1992, a cargo ship started to leave Hong Kong and ended up in a storm and was carrying only ducks, these yellow plastic ducks. That cargo ship came in a storm and 28,000 were washed overboard. It's a true story. So it was actually a massive tracking experiment, which actually oceanographers all over the world concluded that all of these theories of the currents and so on are right. And beyond this, because basically currents and gyres and so on, they're more on the surface as well, weather-driven. But there is what is called the ocean conveyor belt. All that ocean worldwide is connected. It takes a water molecule 1,000 years to go around in every single ocean. And what you see here is not only horizontal, the movement in horizontal space, but also in depth. This is more recent knowledge that we have now of that beautiful ocean. You have the overturning points in the Arctic. Also, it is a big tipping point in the northern Atlantic. This is slowing down because of the sea ice, because of glacier ice, sweet water, the ice sheet on Greenland that is interfering with that salty warm water. Everything is changing and slowing down. Also here, overturning. What does that mean? Water goes down, sinks, and goes the other way again. That's the blue dashed line. See? It is based on temperature differences, salinity differences, in essence, both density. This is essential. This is the basis for understanding our ocean. So we need science. This is the Belgica, an example of a Belgian research vessel. We need to understand what is happening with that water. That water is becoming saturated, takes up so much carbon that it's getting acid. Acidification of our ocean has implications for every single skeleton-based creature, including corals and so on. So these are sampling bottles with instruments attached. I'll get a bit faster here. The clue is they're measuring worldwide, and this is also my work to document this, day and night, around the clock. It's going in the water column, taking samples. Every single bottle will take a little bit of water on a certain depth on one geoposition. The ship is stationary for hours. This thing goes down up to 5,000 meters, sometimes even deeper, then comes up, sometimes in stormy weather. This was January. It was not easy taking these photos. Why? Well, they want to understand processes and change. And this is the beauty of science. As you also know, you're a medical scientist. Collaboration. All of these people spoke a different language. It's really beautiful. Anyway, so more and more, we're gathering information, trying to understand why, while these people are taking samples, we're taking up a deep net, a plankton net. And this happened in front of the coast of Sardinia, which is the Mediterranean, just random, taking some plankton and then having a look, and a closer look. And then you see, unfortunately, plastic. All of these confetti, as I call it, the colored particles, it's everywhere, in every depth, in the air, it is everywhere. So to conclude, we need also monitoring systems, instruments. This is an Argo float. It's a very, very basic and so efficient system. And so I show you some photos of how we deploy them. These are floats, we release them, and for 10 years, they're going around. About 10 years, so as long as the battery takes, 8 to 10 years. And they release themselves with a whole system, mechanical system, hydraulical maybe, mechanical, I don't know. So 10 hours at the surface, then they descend to 1,000 meters, they drift, they descend even more. They do exactly the same. The only thing they don't do is taking samples. They measure conductivity. Conductivity means, we can understand the density because we understand the salinity and so on. They, of course, measure temperature and so much more. They come up and they send everything via satellite systems to the land servers, and it's all open source. Worldwide, we have thousands of these kind of instruments, where Argo is only one of them. This is the biggest umbrella is the Global Ocean Observation System, GOOS. And you see here some of the floats, also Argos, to give you an idea of how scientists are really trying to understand the ocean. So what is needed? Well, we need to, get aware. I try to raise awareness with imagery, and I also try to build bridges. I do that now for the last 6 climate change conferences. I found this photo. I will be going to Turkey as well for COP31, because that's really where the whole world meets. Every country, scientists, Industry and policy, we need all of them. And they speak different languages. That's why I tried to use photography as a universal language. This is a Senate, Federal Parliament of Belgium, the European Environment Agency with a beautiful outdoor exhibition in Denmark. And I do a lot, and I have a lot of help from Foreign Affairs in Belgium with embassies. That's the Belgian embassy in Switzerland. So it's really a matter of time. And I would like to thank you for for being here. Thank you very much. Are there questions, maybe?
Well, this was really an honor to see all of this. Just beautiful photography and a beautiful narration. Well, I mean, not a beautiful narration, not a pleasant story completely of this narration, but well done. Thank you very much.
Thank you.
So I'm a physiologist, and we teach and study about humans and animals, because humans are animals too. I know you know that.
They are. No doubt.
And so what we need most of anything, talking about seeds, sargassum, soil, water, is we need this one little mineral called magnesium. Because without magnesium, we don't have the battery juice that drives our cells called ATP. We need a magnesium ion to put a phosphate on the last, as the last element of ADP to make ATP. And without ATP, we have no metabolism in our cells. All our cells would die. And so I think what you have shown, well, it's been shown that soils are depleted of magnesium. There's a whole worldwide magnesium deficiency. Have you heard of that? And have you thought about how to incorporate this magnesium story? Because I think that magnesium is the link, or could be one of the links, important link to humans and animals. Plants, the seeds being depleted of magnesium, and then therefore we have no battery juice. Your comments.
Well, I can only say thank you for this contribution. I will do more research on the effect on magnesium and the importance of it. Thank you. Anyone? Yes. Well, we have concepts now like planetary boundaries. 7 out of 9 are crossed. We have concepts such as, what's the name now? Tipping points. I think 2 of them are crossed, about 10 tipping points. So are you asking my opinion or scientific? Well, I think we should be worried about the biosphere, about plastics. What is my opinion on this? Well, I really try to be hopeful, but it's getting harder. That's my opinion. It's getting harder because I am not only on the front line seeing the phase of climate change and the change. I call it change now because it's environmental change, cultural change, animal change, plants change. Everything is changing rapidly. But I'm also at the front line with scientists, and they are telling me a lot, and I'm asking them a lot, because in my heart, maybe, I was showing my brain, but it's actually my heart, I am a bit like a scientist. I really want to know, to understand generally with rational facts. I want to understand what I'm taking photos of, also to be able to explain to the world. It's not going well. And the ocean has been really underestimated, not only in importance, but how sick it has become. And I don't know if you know Sylvia Earle. I know her personally. She always says, no water, no life. No water, no life. And then she says, no green, no blue, no green. Think about that. We really need that ocean. Another thing I didn't actually mention that, there's so many things I can still mention, is over-exploitation. We are not managing nothing, well, I shouldn't say nothing, but very little things related to the ocean are really sustainable. We take and take and take, in terms of taking animals then. So yeah, thank you for that question. I hope the answer was satisfying. Yes, sir.
Thank you. And it's just wonderful. And thank you for mentioning the birds of the day, like the penguins. I understand from what I do about birds that also that the birds at the sea actually are much larger in number than many of the ones that are in land.
Seabirds, yes. Definitely. The first thing I think of for seabirds is plastic, but the second one would be invasive species. Because a very beautiful example is my number one species. I get this question quite often. What is your favorite animal? It would be albatross. It's very inspiring. Albatross is a seabird. It spends so much, like, I don't know in percentage, let's say 90% of its life at sea. And it uses the thermic, you know this bird, right? Now this bird has to breed, cannot put eggs on the sea, so they need land. And where do they do that? And in many cases of seabirds, they do that on small islands that they find in this vast ocean covering 70% of our planet. And on almost every of these small islands, you have rodents, rats, mice. You have sometimes cats being introduced to cope with rats and mice, but then cats are eating birds. You have, you know, so many pressure and stress on these populations of birds. And I can give examples, but maybe we have a lack of time. But I have an entire slideshow on specifically invasive species and examples like Tristan da Cunha and that group, Gough Island, Kerguelen, the French islands. I've been to all these places with scientists and I documented, I saw it. And I give you one example, Gough Island. Gough Island has now a really big problem. So because of rats, there was a shipwreck about 200 years ago, Portuguese ship wrecked. There was a rat, either a pregnant woman, or female rat, I should say, sorry, not woman, a pregnant female rat, or maybe a male and female, so they flourished. Now these rats are extincting, is that a verb? Like driving the Tristan da Cunha albatross, specifically this species from albatross, to extinction. And they do that because they massively attack the mother who is trying to protect, and she cannot because they're coming from everywhere simultaneously. So they evolutionary also know now how to cope with that. There is footage about that, so it's really interesting. Yeah, pleasure. Thank you for the question. Anyone? Yes, lady.
Okay. Thank you. That was amazing in that presentation. You talked about birds migrating and animal migration and also adaptation. Do you know of any studies that have done on human migration and also, for example, pregnancy outcome associated with climate change?
With climate change, yes.
If you know of any.
Yeah. Well, about the migration, the best example would be the atoll states, and there is a very actual example. I think it's the state of Kiribati, who now have officially being granted citizenship by Australia, because they will lose their land. Atoll states are the first ones to lose their land. There is also in Tuvalu, another that I showed you, there is the, how is it called? It's not metaverse, because that's Facebook or something. I don't know about this, but they're like digitalizing that world to show it to future generations. And maybe you'll read it in the bio, in the little book. I have kept out those photos, but I also tried to contribute, and let's see if I took out these photos. So I have contributed or tried to do my share by many of the photos you saw and so many more. I have stored them in what is called an Arctic World Archive. It is in a microfilm in one of these abandoned coal mines. Same idea, to preserve, and they have ISO standards for 1,000 years. There is no electricity involved, no technological cyber attacks, evolution of technology. It's just binary code, which they will for sure still understand in 500 years from now or later. And it's a document for these people to show how 2019, for example, how these islands were looking like. So, and concerning your question on the pregnancy, well, I am not specialized in that, but I can assure you, yes, there will be effects, for sure. And it's, I would say, most probably because of a lack of certain species. So think of, a bad example, but I think of scurvy, of the first polar explorers and so on. They didn't know. So the Belgica, that expedition, there was one person on board, and he knew. He was a US citizen, Frederick Cook, who actually claimed to be the first to go to the North Pole. That's a different story. But he knew we have to eat penguins. People started to get sick because of lack of vitamin C. And maybe some others as well. You're doctors here, not me. So I know that this is an issue. Think of these island states where nothing, or where lesser and lesser species are growing, right? They have to import everything and so on. And then plastics again. Anyway, no. Anyone? Okay.
Thank you, Christian.
Thank you.
I cannot think of a better way to end our research day. Thank you very much for being here, and thank you to the wonderful support team, IT, amazing, the conference center, amazing, and everybody that came and made this day possible. Thank you very much for being here, and I hope that you will attend the workshops tomorrow. See you at 9 a.m. Thank you.